date of delivery, what we need or use is what is the Naegele's formula, right? So what we use is going to be the Naegele's formula, right? Now, I'm going to give you an example, right, so that you understand how you're going to do this. So suppose your patient says her LMP is 8th of May, right? And let's take it last year, right? So let us say that her LMP is 8th of May 2020. From this, how will you calculate her estimated date of delivery, right? So the first thing I want you to do is you add 1 year to this, right? So that makes it 8th May 2021. Yes? Then I want you to subtract 3 months, right? So go back 3 months, which makes it what? So, which makes it 8th of February, right? So this makes it 8th of February 2021. And the third step is add 7 days. So this makes it 15th Feb 2021, right? So this is the first step. The first step is add 1 year, okay? The second step is subtract 3 months, yes? And the third step is add 7 days, yes? The third step is add 7 days. Now, please remember some very basic things that I told you yesterday. So I told you that, all these calculations are based on what concepts? They are based on that we are taking the average menstrual cycle as 28 days. Yes, but I hope you all understand that if the cycle length will change, this will also change. Yes, so remembering the concepts from yesterday, can you tell me if a woman has 3-week cycle instead of a 4-week cycle, if a woman has 3-week cycle, right, tell me her due date will be earlier than the calculated one or would be later from the calculated one, right? So if a woman has 3-week cycle, her due date will be earlier from what you from the calculated one or later from the calculated one. So then this will be earlier. So her due date will be earlier than the calculated date. Very good, Ayushi. Yes, it will be earlier from the calculated date by 1 week. So calculated in the normal way and then go back 1 week. Yes. Similarly, very good. I'm glad that you're all understanding concepts. Okay. Similarly, I'm going to give you another example. The second example I want to tell you is your patient has a 5-week cycle. Yes. So if your patient has a 5-week cycle, tell me her due date will be earlier from the calculated one or later from the calculated one. What would that be? So this is going to be later. Yes, from the calculated date, and it will be 1 week later from the calculated date. Yes, is it understandable to everyone? Okay. The third example I want to take is, you know that these days we are doing a lot of IVF, right? Where the fertilization I told you yesterday is going to happen, outside the body. That is why it is called as in vitro, right? So how are we going to calculate the EDD from this? So please remember, if you talk about the IVF cycle, right? So remember just one concept. When we say EDD is equal to 40 weeks from LMP, who is going to tell me EDD will be how many weeks from fertilization? Can you tell me? If EDD is 40 weeks from LMP, it will be how many weeks from fertilization? What would be the answer? So it is going to be 38 weeks from fertilization. Yes, this is all based on the concepts that I gave you yesterday. So we are presuming that fertilization is happening in the exactly on the 14th day. Yes. So if EDD is 40 weeks from LMP, it will be 38 weeks from fertilization. Perfect. So in IVF, we know the date of fertilization. Yes. We know the date of fertilization. Do you know what is the date of fertilization? This corresponds to the date of egg retrieval. Okay. So it corresponds to the date of egg retrieval. No, Atul, beta, it will be 38 days. है ना? Fertilization बाद में होता है. Alright? So fertilization से 2 हफ्ते कम होगा. Okay? Right. So in an IVF cycle, the date of fertilization is corresponding to the day of egg retrieval. Yes? क्योंकि जिस दिन हम egg retrieve करते हैं, उसी दिन हम fertilization भी कर देते हैं. So how are you going to calculate the due date now? Can you tell me? Let me see if anybody can tell me now. So for an IVF cycle, what you do is, from the date of egg retrieval, you are going to add 38 weeks, right? So if you know the date of egg retrieval, you will add 38 weeks to get the due date. Yes? Now, understand this. They will confuse you maybe a little further. I told you yesterday that there are 2 kinds of embryo transfer we do. Yes? So I told you there are 2 kinds of embryo transfers we do. We can do a day 3 transfer and we can do a day 5 transfer. Okay? This is what I taught you yesterday as well. So now please understand, sometimes in the exams they may not give you the date of egg retrieval, but they may give you the date of embryo transfer. So what do you do? So if they are giving you the date of embryo transfer, what do? You add 38 weeks to this, and then if it is a day 3 and let's say the value turns out to be X, yes, so we know the date of embryo transfer, you add 38 weeks to it, and let's say the value turns out to be X. Okay, if it is a day 3 transfer, what will be the due date now? The due date will be X minus 3. Yes, the due date will become X minus 3. If it is a day 5 transfer, what would due date become? The due date will become X minus 5. Yes, so due date will become X minus 5. Is this clear to everyone? Yes. So some very, very basic things. This is the first thing we will do, which we want to write down on the ANC card of any woman who comes to your clinic. Yes. Once you confirm that she is pregnant, you want to write her LMP, you want to write her EDD, and then you calculate the period of gestation from LMP as well. Yes. Is it clear to everyone? Now, can you tell me the next basic thing that you want to write on her card? So let's say you are the doctor sitting in the clinic. This lady has come to you. Yes. Let's say she is, 5 weeks pregnant. You have taken down her LMP. You have taken down her, calculated her EDD, and you have calculated the POG. So let's say she is 6 weeks, 7 weeks, whatever weeks pregnant. What is the next very important information that you write right at the beginning of the antenatal card? What do you want to write? Tell me. The next very basic thing that we want to write in the antenatal card is gravida and para. Yes, so we want to write about her gravidity and parity. Very good. Yes, so that is what we want to know. So again, very basic things, but have been asked in the exams in various clinical formats. Yes, so let's look at this. The first thing I want you to know is this. Okay. So gravida is, please remember this, number of times, okay, number of times the woman has been pregnant. Okay, please look at the key words. It is simply number of times the woman has been pregnant. It doesn't matter what the outcome of pregnancy was. The outcome of pregnancy could be an abortion. The outcome of pregnancy could be a stillbirth. The outcome of pregnancy could be a live born baby. So I'm not at all worried about the outcome when I'm talking about gravida. Yes. So I only mean the number of times she has been pregnant. Also, since it only means number of times, will it count the current pregnancy? Yes or no? Will you count the current pregnancy? Yes. So please remember, current pregnancy is included in gravida. Okay. So if she is pregnant for the third time now, she will become G3. Okay. Which also means, can you tell me, okay, can you use gravida for non-pregnant females? Yes. Okay. So you can also use gravida for the non-pregnant females. But because it doesn't make any sense, we don't use gravida once we're talking about non-pregnant females. But gravida can be used during pregnancy. It can be used outside pregnancy. You just have to know the concept that it means number of times the woman has been pregnant. Yes. So is gravida clear to everyone? Okay. Fair enough. We go on to the next one. The next is going to be parity. Okay. So the next important terminology is parity. Okay. So parity is, again listen to the keywords. It is number of pregnancies, or rather I should write number of completed pregnancies. Okay, so number of completed pregnancies beyond the period of viability. So number of completed pregnancies beyond the period of viability. Is it clear? Now let's quickly look at keywords. What do you understand by completed? What do you understand by the word completed? Completed means current pregnancy is not included because it's still an ongoing pregnancy. Completed pregnancy का मतलब होता है कि pregnancy का कुछ अंत होना चाहिए. Yes, so it could be again a live born baby. It could be a stillborn baby. Yes, it could be a preterm baby. We don't care about it. Yes, again we are not worried about the outcome. It could be alive, it could be dead, it could be preterm. Yes. So what we are only worried about is that it should be completed pregnancy. There has to be some result of that pregnancy, right? So please remember this very important thing, that current pregnancy is not included. Second concept, it is again, as I have mentioned, number of pregnancies. It is not about the number of fetus. Okay, if somebody had a twin pregnancy, right, the pregnancy was one, but there were two babies, right, the parity will only say one. Is it clear to everyone? The parity will only say one. So please understand, parity will not change with number of fetuses. Okay, parity will not change with number of fetus, right? The pregnancy may have one fetus, two fetus or three. Yes, but parity will not become 1, 2 and 3. Parity will be counted as 1. Is this clear to everyone? I don't want any, lochas into this. Your concepts should be very clear. Alright? Okay. Then the third thing, that is the keyword here, it should be beyond the period of viability. For all practical purposes, because this formula, the GPAL or GTPAL, these are universal formulas. Yes. By what I mean, you're going to use these formulas in America also, in Europe also, in India also. But the problem is that period of viability is different for different regions. Yes, or countries. So, what is the period of viability in India? Period of viability in India is still 28 weeks. Okay, they have not changed the period of viability. It is still 28 weeks. But for all practical purposes, when you have to write the formula, yes, so for all practical purposes, because this is an international formula, right? we take anything beyond, so pregnancy which is completed beyond 20 weeks is taken as parity, right? So internationally, they say that beyond 20 weeks, it would be counted in parity. What is the problem? I will tell you with the Indian concept, because there will be a gray zone. Yes, but for India, it is still 28 weeks. Internationally, we take it as generally for the formula beyond 20 weeks. Yes, is it clear to everyone? Now tell me this answer. Okay, before I go any further. A lady is pregnant for the second time. Her first pregnancy was twins. What will be her G and P? Can you tell me? A lady is pregnant for the second time. Her first pregnancy was twin pregnancy. How would you write her G and P? So quickly tell me, what would be G here? G will be 2. Yes, because she is pregnant for the second time. Okay. Parity. I want to know from you, what would be the parity? So, since there is only one pregnancy which is completed beyond the period of viability, this would be taken as ones. Was twins, maybe I can say, born at term. Yes, so this is what I am writing. Right? Very good. So, you are all right. Aman, गड़बड़ कर दी बेटा, P2 नहीं होगा. अभी मैंने समझाया अमन, number of fetuses will not change the parity बच्चे. ठीक है अमन, यही सिखाने की कोशिश कर रही हूं. हाँ, ऑल राइट. अब आगे बढ़ते हैं. What is A? So what is A in the formula? A stands for abortions. Yes. So what is A? Pregnancy loss before 20 weeks. Right? Or pregnancy loss up to 20 weeks is called as abortions, and beyond 20 we said we will include it into parity, right? So we will put it as pregnancy loss up to 20 weeks is taken into abortions, right? Now this is what I was trying to tell you, that if you follow the Indian system, there is a discrepancy. What is the discrepancy? हम बोल रहे हैं less than 20 को हम abortion में डालेंगे, more than 28 को हम parity में डालेंगे, बीच वाले कहां गए? Yes, do you understand what is the problem with our concern is? What if a baby is delivered between 20 and 28 weeks? So that is why there is a bigger formula that we should also use. I will tell you that formula also, but here I just want to give you the terminologies, right? So this is why I said that internationally you should take beyond 20 weeks into parity. Is it clear to everyone? Okay. Then what is L? What is L? Now listen to me very carefully. L is number of currently living children. Okay. So L is number of currently living children. What is the keyword here? Currently living. Yes, so the keyword here is currently living, which means if a child was born and dies, let's say 2 days after birth, will you include that child in L? No. Yes, so that child will not be included in L. Now I'll give you another example and I will expand the previous question. A woman is pregnant for the second time, right? So she is pregnant for the second time. Her first pregnancy was twin pregnancy and resulted in preterm delivery at 32 weeks. One baby died because of prematurity and one is living. Can you tell me what will be the GPAL score of the patient? Can you tell me what will be the GPAL score of the patient? So the gravida remains as 2. She is pregnant for the second time. Yes. Parity. What is her parity? 1. Only one pregnancy is completed pregnancy. The current one is an ongoing pregnancy. What about abortions? There is no abortion, right? So A 0. And what would L be? It would be 1. So although 2 children were born, yes, but only one is alive. One baby died. So that baby would not be counted here. Yes, so it will be G2, P1, A0 and L1. Yes, is the concept clear to all of you? Very good. I am saying that all of you have answered correctly. Very good. Now I am going to do the expanded formula for you. Right? So now we have to do the expanded formula for you. Right? So what is the expanded formula for us? Let's do this. So the expanded formula is GTPAL. Now please listen to me very carefully. Now in the expanded formula, the G is still gravida. And it is exactly the same what I have taught you. But what is T here? So this is number of pregnancies, right? Completed at and beyond 37 weeks. Yes, so number of pregnancies completed beyond 37 weeks. Yes, what is P here? The P here is not parity. So what we have done is the parity is divided into 4 other parts, TPAL. Okay, so here P is prematurity. Right, so P is preterm birth. Right? So here the P is preterm birth, which will include all pregnancies that were completed beyond 20 weeks. Okay? But before 37 weeks. Right? So number of pregnancies completed beyond 20 but before 37 would be put under P. It is preterm birth. Again, it is number of pregnancies. It is not number of fetus or babies. A is still the same. It is abortions. So number of pregnancies that ended before 20 weeks. Yes. And what is L? That is also the same, number of currently living children. Right? So number of currently living children. Now, you are going to quickly use the same example that I have given above and give me the answer now in the terms of TPAL. Right? So the question is the same, which is a lady is pregnant for the second time. Yes. Her first pregnancy was twins and resulted in preterm delivery at 32 weeks. One baby died and one is living. So what would be the expanded formula? Right? The expanded formula would now be, the G will remain 2. T. Is there any term delivery? No. So the T becomes 0. Yes? P. Preterm delivery. Is there a preterm delivery? Yes. 1. Yes? A. 0. And L. 1. Very good. So yes, Apurva, you are right. So it will become G2, T0, P1, A0 and L1. So please remember these are core obstetric concepts. Even exams like INI CET have asked these things recently. Yes, so it's not about high funda cheezein kitni aati hain. It's all about how much concepts you know and how much you are able to grasp them and how much you are able to clinically apply. Yes, so now I hope you will not make any, wrong statements when we come on to this. Yes, okay. So before I go any further, I want you to solve these 2 questions for me. Right? So let us look at the first question. This is based on yesterday's concepts. It's a recall for you and then I start with another question. So your patient has She's 27-year-old. She has history of missing her period and says her LMP was 5 weeks back. Okay. Her cycles are regular in 28 days. She feels sick. She is concerned that she might be pregnant. Which of the following is the next step in her evaluation? So this is what I told you. This is a typical example how the woman would present, and I'm sure you all know what you're going to do. What are you going to do? Yes, you are simply going to do a urine pregnancy test. Please remember, it is not important right now to do a transvaginal ultrasound. What you do next is a urine pregnancy test. Will it be positive? Yes. Why? Because it says 5 weeks back. So that's what I said. The urine test will become positive 1 week after the missed period. Yes? Alright. Then, so concept clear to everyone? Let's look at this one. Okay, this is again, let's see if you are able to quickly give me the answer. Your patient with the first day of her ILMP on May 7th, yes, presents for her first obstetric visit at 10 weeks. What is the patient's estimated date of delivery? So tell me, what is the patient's? I gave you quickly how to do it. So follow the steps. What is the first thing? Add 1 year. So if you have to add 1 year, you know, the same year options become wrong. Yes, so the first step was add 1 year. What was the next step? Subtract 3 months. So if you go back from May, it will be February. Yes, but it cannot be the same, date. Yes, so how much you have to add? You have to add 7 days. So you simply follow the 3 rules. Add 1 year, subtract 3 months, and then add 7 days. Yes, so the answer is B. It would be February 14th of the next year. Is it clear to everyone? Yes? Okay. Alright, let me see if you can give me the answer for this one. Your patient is 44-year-old. This is her obstetric formula, right? She is coming to you for her OB visit, right? Tell me, how many full-term pregnancies did the patient have? So come on, tell me. I told you in the expanded formula, the P is divided into TPAL. So here it is like this. Yes. So what is the number of term pregnancies? What is the answer? The answer is C. It will be 3. Yes. The answer will be C. It will be 3. Yes. So do you all understand कि ऐसा कुछ नहीं है कि हम basics में से clinical MCQs नहीं बना सकते? Yes. So I have simply brought these things so that you do not make gross mistakes. Alright. So the answer is C. Sanskriti, it's not 5 beta. 5 last वाला जो है वो है currently number of living children. Okay, Sanskriti? Yes? Alright. So this is the basics and how I want you to learn the application. Yes? Now this patient, let's recall our patient. Who was our patient? Our patient had come to us with amenorrhea. She had come to us with nausea and vomiting. We did a UPT. It's positive. I have noted down her LMP. I have noted down her what? Or calculated her EDD, and I have calculated her period of gestation. Yes, so now I have done all these things. Yes, can you tell me, in case your patient does not know LMP, let's change it. Let's just say this lady comes and says, Doctor, I don't know, I think I might have missed 2 months, I might have missed 1.5 months, right? Now, if someone does not, remember her last menstrual period, what do you think is important now? So, the calculation of period of gestation, I told you, is from LMP. But I am saying our next patient, so if we call the next patient into the OPD, our next patient says she does not remember her LMP. She says, I am having 2 months of amenorrhea and I don't remember my LMP. Right? Yes. So then what are we going to do? How are we going to calculate her POG? How will we calculate her EDD? Yes, and I am sure once you are going in, start seeing patients in your antenatal OPDs, you will realize this is a very common patient. Hai ki nahi? Hai na? So, especially if uneducated women are there, they will say, I don't remember. Right? So, Sanket, beta, fundal height गलत आंसर है. कल मैंने एक बहुत बेसिक सी चीज बताई थी संकेत. When does uterus become an abdominal organ? Tell me. When does uterus become an abdominal organ? At 12 weeks. Do you think this uterus will be palpable parabdominally? No. Right? So PA exam pe uterus will not be palpable. Okay? In this patient, do you want to do a PV exam? Tell me, yes or no? So this is what I want to ask you. Do you want to do a PV exam? Yes. To know the size of the uterus. But, so although it gives us a rough idea, I told you yesterday that if she is 6 to 8 weeks, it will be the size of a pear. If it is 8 to 10, it would be the size of an orange. If it is 10 to 12, it would be the size of a grapefruit. But is this a reliable method? So this is not very reliable. Yes, so it is not very reliable. Why? Because it needs expertise. You should know what different sizes of uterus feel like. Yes, and it is not, does not give you the exact size. It gives you a range. Okay, it could be 6 to 8, it could be 8 to 10, right? So, which means what would be a reliable method? Right? To know her POG. Yes? So then, to know her period of gestation or to know her EDD, it would be ultrasound. Yes? So this is a patient who will need an ultrasound to know her period of gestation and to know the estimated date of delivery. Yes? Now quickly tell me, what is the best marker of period of gestation? So please remember, ultrasound in the first trimester. Yes? So ultrasound in the first trimester is the most reliable method to know the POG. Yes? To calculate the POG, ultrasound of the first trimester is the most reliable method. Okay? Now, can you tell me what parameter do we study in such a woman? So suppose you write down to her, okay, you have to get an ultrasound, right? So what parameter are you going to study to calculate this? So the best parameter for gestational age assessment. Yes? So best parameter for gestational age assessment is, you are all right, it is crown rump length. Yes? So it is the crown rump length. Yes? So I'm going to show you certain images. Okay? And these images are already given in your concepts books. So you don't need to click any pictures or anything. They're all there in your concept books. I've picked them up from the concept book only. Yes. So this is how you are going to measure the crown rump length. The reason I want you to see this is that you have to understand when you say crown rump, what do you understand? So crown means it has to start from the head of the baby, and it has to go to the rump or the buttocks. Please see that limbs, okay, so limbs are not included in this calculation. Yes, so limbs are not included in this calculation. Is this clear? Okay, so I am saying CRL is the best parameter. So among all parameters, this is the best one. Okay, but up till what time can you use crown rump length? So we will use CRL to calculate POG or EDD. Yes, up to the 14th week. So up till 14th week, the best parameter becomes crown rump length. Yes, so up to 14 weeks, the best parameter becomes CRL. Okay, now please remember this. Although up to 14 CRL is the best parameter, your exams may ask more depth. Okay, so the more depth is, what is the ideal time to measure CRL? When I say ideal, it means it will be most accurate. Yes, so if you do it in this time, it will be most accurate. It will be nice if you can write all these things in the concept book itself. Yes, I am sure your concept book does have space at the bottom. Yes, so it has space at the bottom. So you can use these notes of the images at the bottom itself of your concept book. Okay, you can do that. Right? So the ideal time to measure the crown rump length is between 7 to 10 weeks. Okay, so the ideal time to measure it is 7 to 10 weeks. Yes, is it clear? Okay. I have said that you can use CRL only up to 14 weeks. Okay, what parameter will be used beyond 14 weeks? So beyond 14 weeks, what is the best parameter? Okay, so beyond 14 weeks, what is the best parameter for gestational age assessment? Right? Now what is going to be the answer? So now the answer is going to be biparietal diameter. Right? So up to 14 weeks, the single best answer is CRL, and beyond 14 weeks, the best parameter becomes the biparietal diameter. Right? Let's look at biparietal diameter. So this image actually tells you where should you measure biparietal diameter. So to take a correct measurement for biparietal diameter, you should be able to see the third ventricle and both the thalami. Yes, so you will take the image at a plane where you are seeing the third ventricle and you are also seeing the thalami. Then you take the dimensions as shown. Yes, and this is the correct calculation of BPD. Yes, so this is the correct calculation of biparietal diameters. Is it clear to everyone? Yes? Okay. What is the difference between HC and BPD? HC stands for head circumference. Yes? हेड सर्कम्फरेंस को कब यूज करेंगे इन प्लेस ऑफ बीपीडी? सो हेड सर्कम्फरेंस इज यूज्ड इन प्लेस ऑफ बीपीडी इफ द shape is distorted. Right? So if the shape of the skull is distorted, then instead of the biparietal diameter, you will use what? Head circumference. Is it clear? There is very little difference between BPD and HC. HC becomes more accurate when there are changes in the shape of the head. Yes? Now please remember, HC लेने के लिए भी same चीजें चाहिए. We need a plane okay, which will show us the third ventricle, which will show us the thalami, but now it should also show, okay, cavum septum pellucidum. Okay, so now it should also show the cavum septum pellucidum. Is it clear? So it's almost the same level, but before you start taking the measurement of HC, you should also visualize the cavum septum pellucidum. Is it clear to everyone? Okay. If you talk about fetal biometry, ये सब जो हम देख रहे हैं, crown rump length, biparietal diameter, what is all this? This is fetal biometry. What are the other two measurements that you take in fetal biometry, right? The other two measurements in fetal biometry become femur length. Yes. So this is how we will calculate the femur length. We are not including the condyles. Yes. So femur length, and yet another parameter becomes the abdominal circumference. So when you say you are doing fetal biometry, you are actually going to look for all these four things. You look for CRL, you look for BPD, you look for femur length, and you look for abdominal circumference. Is it clear to everybody? Okay. Now when it comes to abdominal circumference, at what plane do you have to take it? So the plane is already mentioned. In the abdomen, where the umbilical vein meets the hepatic veins or the portal sinus. So if you see, this area is seen like a hockey stick. Yes. So this area where the umbilical vein meets the portal vein, it gives the image of the hockey stick, right? And if your probe is in the correct plane, you will also see the stomach bubble, as you can see here. So if you are seeing the stomach bubble, it means your plane is right, and now you can take the measurement. Yes? Okay. Now please remember, out of all the four parameters, biparietal diameter, femur length, crown rump length, AC, which is the least useful for gestational age? It is abdominal circumference. Okay, so this is the least useful parameter for gestational age assessment. But can you tell me on the contrary, abdominal circumference becomes the single best parameter for what? It becomes the best parameter for what? It becomes the best parameter for fetal growth. Yes? So, it is the least useful parameter for gestational age, but it is the most useful parameter for assessment of fetal growth. Alright, so whether you want to look for macrosomia or whether you want to look for IUGR, right? So whether you want to look for macrosomia or you want to look for IUGR, the best parameter will be AC. Okay, normally we say if AC is more than 35, it means there is macrosomia. Yes, so if AC is more than 35, it means there is macrosomia. And if AC is less than the 10th percentile, then we will say it is IUGR. Yes, then we will say it is IUGR. Yes, is it clear to everyone? Okay. Now, can you tell me, apart from gestational age, what else is the use of this parameter? So, gestational age ho gaya, fetal growth ho gaya. What else would we use fetal biometry for? What else will we use fetal biometry for? Can you tell me? So, fetal biometry is also used for what? For calculation of EBW. Okay, so fetal biometry is used for calculation of EBW. What is EBW? Estimated birth weight. Yes, so whenever the radiologists are going to do an ultrasound, yes, they are going to calculate the weight of the baby from these parameters, right? So EBW is the estimated birth weight, and the best calculation of EBW is when you use, is when you use all the parameters together. So which means we will use BPD, we will use FL, and we will use abdominal circumference. So all parameters are together, the best way of calculating the estimated birth weight. Now I have to understand whether you have understood or not. So now tell me, for estimated birth weight, what do you think is the best way? Is it the combination of this, or is it AC alone? This is called as Hadlock's formula. Okay, so when you use all these parameters together, it's called as the Hadlock's formula. The ultrasound will do the calculation for you. You don't have to do the calculation. But what I want to know from you is Hadlock's formula more accurate, or is AC more accurate? That's what I want to know. So obviously, the more parameters you will use, more accurate it will become. So Hadlock's formula is more accurate than AC alone. But in the exams, we are very fond of asking single best parameter. तो वो कभी गलती मत करना. If the keyword is single best parameter, then the answer will remain as abdominal circumference. Is it clear to everyone? Yes, I hope there is no confusion. Yes, so fetal biometry is important. It helps to keep a check on the fetal growth. It will tell us the period of gestation. It will tell us the estimated birth weight. Yes, is it clear to everyone? Okay, now let's move on to our next patient. So this was just an example that every time, there will not be a patient who knows her LMP. Sometimes there will be patients who don't know their LMP, and then you should know what you have to do. Okay. Now, going on to next patient. Should we call the next patient to our OPD? Yes. So let's call the next patient to our OPD. Yes. Now, this is a patient who is, let's say, 6 weeks pregnant. Yes. How did I calculate 6 weeks? I have calculated it from her LMP. So next patient, let's say, is 6 weeks pregnant. She is coming for her first antenatal checkup. Okay. So this patient is coming to you for her first antenatal checkup. You have noted down her LMP. You have calculated the, or any time बेटा, जिंकल जैन, कभी भी अगर आपको बच्चे का वेट कैलकुलेट करना है, all parameters together will give you a better estimate as compared to one parameter. Yes, so Hadlock's can be used throughout pregnancy. It will keep changing, obviously. Yes, so anytime the best estimate of fetal weight will be by the Hadlock's formula. Okay, Jinkle? Right. So she is 6 weeks pregnant. This is her first antenatal checkup. Okay. I have calculated her LMP. I have calculated her EDD, and let us say she is a primigravida. Okay. So let us say she is a primigravida. So she is pregnant for the first time. Okay. Now I want to ask you, what is the next thing that you would want to do for her? What is the next thing that you want to do for her? Right? You have noted these details. What is the next thing you want to do? Will you want to tell her to undergo certain baseline investigations? Yes or no? Yes? So on her antenatal card, you will tell her to get some baseline investigations done. Yes, that is the first thing. What else would you want to do? I will tell you what are those baseline investigations, but what else would you want to do for her? I would want to tell her about her future visits. Yes or no? Yes. She will ask you, Dr. Saab, ab kab aana hai? Yes. So, do the baseline investigations. Tell her about her future visits. What else? Do you want to see whether she is high risk or not? Yes. So, you would want to identify if she is a high risk pregnancy. Yes or no? Yes. Right? So, I would write down some baseline investigations. I will take a history to find out whether she is high risk or not. Yes. I will tell her when she has to follow up with me. Anything else that you want to do? You know, patients aise aate hain. So if you look at the a little lower class, they are not happy अगर डॉक्टर उनको कोई दवाई ना दे. वो कहते हैं बस डॉक्टर साहब मैं जाऊं, आपने बोला उसको सब ठीक है, आप जाओ, आप दोबारा आना. हाँ, सो पेशेंट बोलती है अच्छा मैं जाऊं डॉक्टर साहब, अब आप कुछ नहीं दोगे, कोई दवाई ववाई नहीं खानी है. यस, सो पेशेंट्स आपसे चाहते हैं कि आप उनको कोई दवाई दे दो. तो कौन सी दवाई दोगे? आपने उसे बताया भाई दवाई इज नॉट सेफ, आपको दवाइयां प्रेगनेंसी में नहीं खानी है, बट कोई ऐसी दवाई है जो तुम देना चाहोगे? क्या करना चाहोगे? सोचो और मुझे बताओ क्या करना चाहोगे. राइट, सो डू यू वांट टू गिव हर फोलिक एसिड बच्चे? यस, सो वी वांट टू गिव हर फोलिक एसिड सप्लीमेंटेशन. अब यहीं पे आई वुड नो दैट आप लोग गड़बड़ करोगे. आपने लिखा IFA, गलत जवाब. आयरन फर्स्ट ट्राइमेस्टर में नहीं देना. आयरन विल बी एडेड आफ्टर 12th वीक. ओके, सो आफ्टर 3 months आयरन विल बी एडेड. अगेन दूसरी गड़बड़, संकेत, कैल्शियम भी नहीं देना. व्हेन विल यू ऐड कैल्शियम? After 3 months. Yes, so after 3 months you have to add iron. After 3 months you have to add calcium. ठीक है, so अभी क्या देना है, कौन सी दवाई देनी है? सिर्फ फोलिक एसिड. अभी मैं इन सारे पॉइंट्स के डिटेल्स के बारे में बात करूंगी, बट मैं पहले आपको पॉइंट्स लिखाना चाहती हूं. राइट, सो पहले हमने क्या किया? बेसलाइन इन्वेस्टिगेशंस, tell her about future visits, identify high risk, and give her folic acid. Anything else that you want to do? अतुल बेचारा बार बार लिख रहा है और सोच रहा है मैम मुझे अटेंशन ही नहीं दे रही. सो अतुल इज वेरी राइट. अतुल, आई विल गिव यू ड्यू अटेंशन व्हेन इट्स रिक्वायर्ड. राइट, सो अतुल ने बहुत अच्छी चीज बताई. क्या बताया था अतुल? अतुल ने बोला एक इंजेक्शन लगा देते हैं इसको. कौन सा इंजेक्शन लगाएं भाई? कौन सा इंजेक्शन लगाएं? प्रोजेस्टेरॉन का? So no, you have to give her injection. कौन सा? This is what I want to know from you. DT. Yes. So injection कौन सा देना है? I want to give her injection DT. ठीक है? So yes, DT has to be given early in pregnancy. Ideally, give it at the first antenatal visit. Okay, right? फिर मैं फॉलो अप भी बताती हूं. दूसरा कब देते हैं? आफ्टर 4 weeks, और आई विल राइट इट एज DT1. आफ्टर 4 weeks of TD1 she will get what? TD2. Right, so after 4 weeks of this she will get TD2. Or what about booster? What about booster? Booster कब देना है? If pregnancy occurs within 3 years of previous pregnancy. Which was fully immunized. ठीक है? Is this clear to everyone? Right? So, give her second dose after 4 weeks. And in case हमारी patient तो primary gravida थी, but if she was not a primary but a multi-gravida, then we will give her the booster. Yes? Which should only be given if the previous pregnancy was within 3 years and it was a fully immunized pregnancy. Is it clear? Yes? Now, let's go from bottom to top. So, I have given you all the details of what? I have given you all the details of DT. It's no longer TT, it is now DT या TD. Okay? Going to folic acid supplementation. What should you know? Folic acid is given for prophylaxis. Okay? And it is given to all pregnant women. Right? Then she has to receive the full 2 doses beta. Okay? Sanskriti, then she has to receive the full 2 doses. Okay? So, prophylaxis given to all pregnant women. Yes? And what is the dose? It is 0.4 milligrams. It is 0.4 milligrams. ये patient तो हमारे पास pregnant होने के बाद आई है. Ideally, when should you start FA? Ideally to be started at least 1 month before conception. So ideally it should be started 1 month before conception. But कोई बात नहीं, जब भी patient आएगी, we will start her. So she is pregnant now and she has come to us now, so we will give it to her now. Yes? Now, coming to the next point, so I'm going from bottom to top. I said we want to know if she is high risk pregnancy or not. So quickly tell me, what all do you think are included in the high risk pregnancy? So please remember these points. So pregnancy which has a current or a past systemic illness. Right? So she may be diabetic, she may be hypertensive, she may be a case of epilepsy, we did it yesterday, or any other thing. Right? So current or past systemic illness. What else? If she is a patient who has diabetes mellitus, if she has or is HIV positive, okay? We will talk about IFA अमर. अभी don't jump. सब कुछ करेंगे, लेकिन step by step करेंगे. ठीक है? So then HIV positive or syphilis, right? Then women who had preeclampsia or chronic hypertension. Then women who have severe anemia are also counted as high risk. Then women with multi-fetal pregnancy. Okay, so women with multi-fetal pregnancy. Then women who are at extremes of age, which means she could be less than 20. So we take it as less than 20 years or more than 35 years. So extremes of age, yes. Then women who have previous cesarean section. Women who have placenta previa. Okay, so PP is placenta previa. Then women who have malpresentations and women who had previous bad obstetric history, right? So bad obstetric history could be ranging from stillbirth, okay, to abortions, to preterm labor, to obstructed labor, right? So then we will consider it as high risk pregnancy. ठीक है? IVF को हम as such high risk ना बोल के हम precious बोलते हैं. ठीक है? So per se in the list, if it is given for some reason, let's say she had previous multiple abortions and now she's undergoing IVF, then yes, she is definitely high risk. ठीक है? Is this clear to everyone? And lastly, something which is very important for us is to know if she was a case of hypothyroidism, right? So if she is a known case of hypothyroidism. Is it clear? So this is the list given by the government of India in their document, right? So this is a direct list from the GOI document. Okay? Now, moving further. So we will take all this relevant history from her. Moving further and coming to baseline investigations. So now tell me, let's presume you people are seeing this patient who is a primea gravida, yes, and she doesn't have any other high risk history, okay? Can you tell me what all investigations would you want to write for her? Chalo batao. So what all investigations do we want to write for her? So we definitely want to write blood group and RH typing, yes? We want to know her hemoglobin, but usually we will write a complete blood count. Then what else do you want? HIV status and HB-S antigen status, okay? VDRL, the test for syphilis. And torch. We want to see whether she has the immunity or not. So these are the blood investigations. What else do you want to do? You want to do a urine RM. So you should do it once in the first trimester. I told you this yesterday also. Now before I go any further, I want to ask you here, do you ask the patient कि मैडम आप HIV का टेस्ट कराना चाहते हो या आप उसको लिख के दे देते हो? बताओ. Do you ask her, ma'am, do you want to get tested for HIV, or do you simply write her and say get an HIV test done? Yes? So tell me, which of the two are you going to do? So we don't ask the patient. Yes? We write it down for her in the baseline investigations and we want her to do it. But patient can refuse. She can say, ये मैं test नहीं कराऊंगी. What is this kind of screening called as? What is this method of testing called as? So for HIV, we are using what technique? Opt out. Okay? Opt out. It is called as opt out. So you have to write it for her. She may opt out of the testing. Right? So the HIV testing is opt out. You as a doctor have to write it, but she may not get it done. So she is opting out of it. Yes? Is it clear to everyone? Okay, perfect. Now, so we have written all these investigations for her. She is very happy with you. आप बहुत अच्छे डॉक्टर साहब हो या साहिबा हो, right? और वो कह रही है कि मैं आपको ही दिखाऊंगी throughout my pregnancy. मैं तो आप ही के पास आऊंगी, मुझे आप बड़े अच्छे लग रहे हो, right? So you talked to the patient nicely, you gave her good attention, you took a good history, you explained her about the drug she needs, you got a TD done for her. Now she is asking you, I want to come back to you only. Yes? So when does she come back? What is the sequence in which the patient has to follow up? Okay? So first, this is what you need to know. As per the Government of India, okay, as per the Government of India, what is the minimum number of ANC visits? So the minimum number of ANC visits as per Government of India is 4 visits. Okay, so as per the Government of India, it is going to be 4 visits. Yes, by which they mean the first visit within the 12 weeks. Right? Then the second visit could be between 14 to 26 weeks. Okay. The third visit can be any time between 28 to 34 weeks. And the fourth visit can be anywhere between 36 to term. Okay. So minimum requirement is 4 visits as per Government of India. Can you tell me as per WHO, and obviously you have to answer this because बड़ी कम जगह हमारी national guidelines हैं. But what is the minimum number of ANC visits as per WHO? So as per WHO, it has to be a minimum of 8 visits. But in our national program, it is a minimum of 4. Yes? And what is ideal? So ये तो है minimum requirement. Ideal क्या है? Right? So the ideal requirement is monthly. So she should come every month, once every month till 28 weeks. Okay? Then she will come every 15 days between 28 to 36 weeks. And then she will come every week from 36 weeks to delivery. Yes, so this is when she is not a high risk pregnancy. This is simply the ideal way of following her up, right? In high risk pregnancy, you may need more frequent visits. Yes, so in a high risk pregnancy, you may need more frequent visits. Is it clear to everyone? Yes? Okay. Now, once we know this, the next thing is that we are going to tell her that she can go. Right? And she can come back to us. Yes? But please tell me, before she goes away and you tell her to come back, yes, can you tell me, would you want to tell your patient about some warning signs? Yes or not? So you will tell her, see, you can come and visit me next month, okay? But in case you have any of this, then you come SOS. Yes? Do you want to tell her this or not? Right? So ideal है जब सब कुछ ठीक चल रहा हो, but you should tell your patient the warning symptoms, right? And warning symptoms would mean that she will have to come outside these visits. Yes? So outside these visits, she has to come to you. Okay? So the most important warning signs is what we are going to write, right? Which is what you're supposed to tell to the patient as well. So if she develops fever, which is more than 38 degrees for more than 24 hours, okay? Second, if she develops any pain abdomen. Third, if she develops any bleeding per vaginum or she has any discharge per vaginum. Yes? Fourth, tell her to come if she develops headache or blurring of vision. Yes? So tell her to come to you if she develops headache or blurring of vision. Then, if she perceives reduced fetal movement, although this is too soon to feel for fetal movements, but since I am making you write the warning signs, you should know them at one place. I don't want to write them at different places, right? So reduced fetal movement. If she develops generalized swelling, please understand, I am not saying edema of feet. I am saying if she develops generalized swelling, which means specially if she is developing puffiness of face, right? So generalized swelling is important. If she is developing any kind of palpitations or breathlessness, but can you tell me what do you want to add? This is a normal thing. This is not a warning sign. When does it become a warning sign? If she develops palpitation or breathlessness at rest, that is what is worrisome. Maybe she is having severe anemia and she is in impending heart failure, right? So palpitations and breathlessness can happen with exertion. That's a physiological thing in pregnancy. But if she is developing these things at rest, then it is worrisome. Yes? Okay. Then if she is having any pain with urination, I told you it is possible that pregnancy may infections can become more serious, right? So tell her if she is developing any pain with urination. Yes? So this is what you tell her as warning signs, right? Now, your patient, let's presume, tells you, okay, so you explain her all these things, and now there is something else which is also very important, right? So she is coming to you, let's say at 6 weeks. When do you want her to come next? So very important. Do we do some routine screening in the first trimester? No, Sanskriti, usually it will subside. Okay, if it's less than 24 hours and it is subsiding by its own, it's not something to worry about. But if it is high grade fever for longer times, it can be dangerous for the baby. Okay? Right. So tell me. What was I saying? So what I was saying was, yes. So you are sending her off. Is there anything else that you want to do in the first trimester in this patient who's come to you as screening? Anything that you want to do? Do we do any screening in the first trimester? So torch we have already written. Okay, so torch we have already written. But anything special that you do here? So very, very important. The two things that you have to know is, at the first antenatal visit itself, okay, so at the first antenatal visit, yes, very important, good Ayushi, you have to do a screening for diabetes. Please remember, this is a GOI recommendation. It is a part of our government recommendation. राइट सो अब जो रिकमेंडेशन है वो बोलता है स्क्रीनिंग शुड बी डन फॉर डायबिटीज एट द फर्स्ट एंटीनेटल विजिट एंड इफ इट्स नॉर्मल इट हैज टू बी रिपीटेड at 24 to 28 weeks or beyond 24 weeks. Can you tell me the logic behind this? कल हमने पढ़ा था. Why do you want to do it at the first antenatal visit? You may be missing an overtly diabetic patient who really doesn't know that she is diabetic. Yes? The second important thing, if it's normal, you have to tell her कि अभी normal है, but 24 weeks पे ये जांच दोबारा होगी. Why? Because then she can develop gestational diabetes. Yes? So you will screen at the first antenatal visit and you will screen if it's normal again at 24 to 28 weeks. Yes? So not maximum resistance but significant resistance palak. Okay? What test will we do? We do the DIPSI test, but this test ke details I will give you in the chapter of diabetes because वहां पे मुझे ये anyways पढ़ाना पड़ेगा. So I will give you the details of the DIPSI test in the chapter of diabetes. But here you have to know that you have to do the DIPSI test. What is DIPSI? Diabetes in Pregnancy Study of India. So these are again the Indian guidelines. Just to give you a little knowledge, we do a 75 grams OGTT. Okay, so we will do a 75 gram OGTT, and it's also called as 2-hour OGTT. Okay, it's also called as 2-hour OGTT. How do we do the test? What are the values? I will tell you when we do the chapter of diabetes. So here I just want to give you the name, and I want to tell you that it has to be done at the first antenatal visit. Okay. Any other screening that you want to do? Very good. So Ria is right. The second screening that we want to do in the first trimester, and we want to do this screening for all pregnant women. Right? So we want to do the screening in the first trimester itself. We want to do it for all pregnant women. Yes. And this screening is going to be what? Downs screening. So please understand, Down syndrome screening has to be offered to all pregnant women. Yes, she may refuse to get it done. Okay, so she may refuse to get it done, but as a doctor you have to advise, right? Please remember, age is no longer the criteria to decide whether the patient should be advised screening or not. So you should advise it for all women, but she may say, okay, I don't want to get it done. Is it clear to everybody? Yes? So now we are going to talk about how and when are we going to advise her for Downs screening. Okay? Right. So what test are we going to do in the first trimester? What test are we going to do in the first trimester? So in the first trimester, the test that we do for Downs is called as a combined test. Okay, it's called as a combined test. Yes, and the combined test has a sensitivity of almost 80%. So it is a good test to be done. Yes. What are the components of the combined test? So in the combined test, there is going to be a serum testing, and there is going to be an ultrasound testing. Yes, so we will do a serum testing, we will do an ultrasound testing. Serum testing will be dual test. So the name of the test is going to be a dual test. And in the ultrasound, what are you going to look for? We are going to look for nuchal translucency. Okay, so this is what we are going to look for. The second question is, when do we do it? Okay, so you are going to call her between 11 to 13 weeks. That's when she is going to get the test done. She can get it done from any lab. Yes, and similarly, the ideal time to look for nuchal translucency is 11 to 13 plus 6, right? So ideal time to look for nuchal translucency is also 11 to 13 weeks and 6 days. Is this clear to everyone? Okay. Then what is a dual test? Okay. So what is a dual test? So dual test has two markers. It has HCG and it has a marker which is called as PAP-A. Okay, so PAP-A is pregnancy associated plasma protein A. Yes, so pregnancy associated plasma protein A. Okay, when does this test become screen positive? When do you say she is screen positive for a dual test? So when HCG turns out to be more than expected, okay, and PAP-A turns out to be less than expected. Okay, something very important. Although we are writing that the dual test has HCG and PAP-A, does the laboratory take into consideration maternal age for calculation of risk along with these markers? Tell me, yes or no? So does the lab take into consideration maternal age to tell you the risk? Okay, so the answer is yes. So maternal age is also considered in risk calculation. Okay, so maternal age is also considered in risk calculation. Please understand, when I say screen positive, does it mean the lab will say this baby has Downs and this baby does not have Downs? So no, okay? No, it does not tell you that. The lab assessment will only tell you what? What will it tell you? The lab assessment will tell you that whether this pregnancy has a higher risk or not, right? So they tell you the risk of Downs. And have you seen how the report comes? So the report comes as 1 in 250, 1 in 300, 1 in 1000, like that. So it tells you the probability of this baby having Downs is 1 in 250. Yes, so it tells you the risk. It's not a diagnostic test. It will not tell whether the baby has Downs or not. Is it clear to everybody? Yes, so these are very gross things. You shouldn't do them wrong. Okay? Then, what is nuchal translucency? Okay, what is nuchal translucency? So I want you to go to your concept book and there is an image there for nuchal translucency. Below that there is space and you can write below that space. ठीक है, उसके नीचे लिख सकते हो ताकि रिविजन करते समय सब कुछ एक जगह हो. So nuchal translucency is what? It is basically a fluid collection. So this is the image from your concept book itself. ठीक है, वहीं से image है, right? So it tells you about fluid collection in the knuckle area underneath the skin. What do we see? Do we see presence or absence? No. Some amount of fluid will always be present even in a normal fetus. Okay, so some amount of fluid will be present in the normal fetus as well. So we are not going to measure whether it is present or absent. We are going to measure how much. So if you see the caliper here, it is measuring the amount of fluid collection. Yes? So if this collection of fluid is more than or equal to 3 mm, it is considered a positive screening test. Okay, it's considered as a positive screening test, right? Now please listen to me very carefully. If we go into more details, we would want to ask you things on how to measure the NT, right? So write down these points. To measure NT, what are the things the radiologist has to keep in mind or has to focus on? So first, it has to be taken in the sagittal plane. Okay? The neck of the fetus, okay, should be in neutral position. Which means not extended and not flexed. So no extension and flexion, it has to be in the neutral position. Okay. Third, the amnion should be seen separately. Right? So amnion is seen separately. What else? The measurement is taken from inner to inner border. So inner to inner border of the collection, and the measurement has to be taken at the widest area, right? So the widest area of the fluid collection is where you will take the measurement. Yes? Now, so this tells you what things you should know about NT. But I want to ask you, what is the significance of NT? What is the clinical significance? So, increased NT, which is more than or equal to 3 mm, right, is seen in Down's syndrome. Can it be seen in other aneuploidies? Yes. It can be seen in other aneuploidies. Right? Like trisomy 18, like monosomy X, which is what is Turner's syndrome. But its highest association is with Down's. Increased NT can also be a marker of cardiac malformations. Right? So it could be a marker of cardiac anomalies or malformations in the baby. How will we ask this question to you? So we will say, a lady has undergone the first trimester scan and her NT is 5 mm, but her karyotype is normal. So once they are saying the karyotype is normal, yes, that means it is not because of aneuploidy. This is a patient in whom you should definitely look for cardiac anomalies in the fetus. So you must later look for cardiac anomalies in the fetus. Is this clear to everyone? Then, increased NT is also seen in twin-twin transfusion syndrome. Right? So it could also be seen in twin-twin transfusion syndrome. Right? So these are some of the important things that you should know, what you should suspect if you are seeing an increased nuchal or knuckle translucency. Yes? So apart from these most important ones, please understand there are other genetic syndromes also which can be linked to increased NT, but you don't have to remember those genetic syndromes or any details of this. They are less common. For example, DiGeorgi's syndrome, right? So there are many such genetic syndromes which could be a cause of increased NT, but as I said, they are less common. So don't take them as the first cause and don't say you will evaluate for that. Okay? I'm just giving you an example that it could be because of genetic syndromes as well. Right? And the typical one that I want to write is DiGeorge. Right? Okay. So this was nuchal translucency and what you should know about it. Now I want you to compare this image with this image. Yes? So compare the previous one and this one. What do you see here? Can you tell me what do you see? So if you see here, and if I zoom it more for you, here also there is a fluid collection. Yes? Do you see? Here also there is a fluid collection. But what I want you to know here is, that when the fluid collection is large, like this, or when the fluid collection extends along the spine, right, or when the fluid collection has septae within it, and this one also has a septa. This is the septa here, right? So it has all the three things. It could be one of this only. So when the fluid collection is large, when maybe the fluid collection extends along the entire spine, or when you say septae within the fluid collection, then this should not be put as nuchal translucency. This is what you call as a cystic hygroma. Yes, is it clear? Is it clear to everyone? Okay. A very basic question I want to ask you. Do you think a cystic hygroma would also be associated with aneuploidy? Yes or no? So if you are seeing a cystic hygroma in a fetus, do you think that this fetus has a higher risk of aneuploidy or no? Yes. So cystic hygroma is also a marker that tells you that there is a high probability of aneuploidy, right? And please remember, the aneuploidy risk is higher with cystic hygroma as compared to what? Nuchal translucency, right? So please remember that the probability that the baby will have aneuploidy is higher if you are seeing a cystic hygroma as compared to if you see a nuchal translucency. Yes? Okay. Now please remember this. Alright? If you see a cystic hygroma in the first trimester, okay, so if you see a cystic hygroma in the first trimester, the baby most likely has Downs. And I'm sure you all know that Downs is trisomy 21. And if you see a cystic hygroma in the second trimester, then this is more linked to Turner's syndrome or monosomy X, right? So cystic hygroma in the first trimester is linked to Downs. Cystic hygroma in the second trimester is linked to Turner's syndrome. Yes, is this clear to everyone? Okay. Again, please remember whether it is a nuchal translucency or whether it is a serum test, they are both only screening tests. Yes, so they are both only screening tests. So if the screening test, which is nuchal translucency and combined or dual test, so the combined test, if it tells you that there is a high risk, right? So if the combined test says your patient has high risk, what are you going to do next? So a typical clinical example will be, they will say, your patient is, let's say, has undergone a combined test and her NT turns out to be 4 mm, right? Or, they are asking you, what do you want to do next? Can you tell me what do you want to do next? So since there are screening tests, now you will have to do a confirmatory test. Yes, so now you have to do a confirmatory test. Okay. Now please remember, the confirmatory test has to be karyotyping, because the only way to say that someone has Downs or not is to see their karyotype, and your karyotype is going to be trisomy 21. Yes. Now for karyotyping you need genetic material. So now, How do we get this genetic material in the first trimester? Tell me, how do I get this genetic material from the fetus in the first trimester? So the diagnostic test that I am going to do now is going to be CVS. It's going to be chorionic villus sampling. Right? So it's going to be a chorionic villus sampling. Yes? Now, I'm going to show you an image, which is the image of chorionic villus sampling. It is there in your concept book and you can write it underneath it if you want. So please remember, chorionic villus sampling is done under ultrasound guidance. Okay? It's not a blind procedure. So we do it under ultrasound guidance. It can be done trans-abdominally or it can be done trans-vaginally. Both have the same pickup rate. So in this image it is trans-vaginal. Yes? And it's very easy to pick up that it is a CVS. Why? Do you see this catheter? Right? The catheter is going into the placental tissue. Yes? So the catheter is going into the placental tissue and this is what tells us that this is CVS. Okay. Can you tell me what tissue am I getting from here? We are going to get the trophoblast. Yes? So we are going to get the trophoblast. So what are the other things that you should know about CVS? When should you do it? So CVS actually can be done at and beyond 10 weeks. But most commonly we will do it between 11 to 13 weeks. Can you tell me why this is the answer for most common? Can you tell me why this is the answer for most common? It's very simple, because this is the time you have done the screening test. So only if the screening is positive are you going in for a CVS. So most commonly it would be done between 11 to 13 weeks. Is it clear to everyone? Okay. Please remember, it should not be done at less than or equal to 9 weeks. देखो मैं बोल रही हूँ प्रोसीजर नहीं करना है, but can you advise at 9 weeks to your patient or not? So if the patient has done the testing and you want to advise her for CVS, can you advise right now or not? Yes, you can advise, but the procedure should not be done at and less than 9 weeks. What will happen if you do it? It will cause fetal limb defects. Okay, so it will cause fetal limb defects, so it should not be done at and less than 9 weeks. Okay, since it is an invasive procedure, right? So since this is an invasive procedure, it will cause some harm to the baby or can cause. So remember that the fetal loss rate, okay, the fetal loss rate with CVS is around 1%. Fetal loss means abortion. Okay? Also, since here you are getting the trophoblasts, which are already dividing cells, do you need to culture this tissue? No. So because there is no need to culture the tissue, what is the advantage? Result can be obtained earlier. So within 48 hours, I can get the result of karyotyping. Yes, is it clear to everyone? Okay. But then, is it directly fetal tissue? No, this is actually tissue from the placenta. But we presume that, placenta and baby are made up of the same genetic material. So the karyotype in the placenta will be most of the times same as the karyotype of the baby. But is there a possibility कि placental karyotyping की अलग report आए और baby की actually में report अलग हो? Is that a possibility? Yes. Although it is not very common, but this is a possibility and this is what is called as placental mosaicism. क्या होता है इसमें? When you get the report, it is a mosaic report. Do you understand what is mosaicism? 2 cell lines. So the report will say half of the cells have a karyotype of which is normal and half of the cells seem to have trisomy, right? So mosaicism means having 2 cell lines. So yes, remember, placental mosaicism is something that you can see with chorionic villus sampling, but it's not a very common thing to be happening. Is this clear to everyone? No, Namita, if your screen is stuck, it happens sometimes when the internet is a little slow, so just exit the window and come back. अगर आपको लग रहा है screen stuck है, so just exit the window once and come back. Okay? Right. So these are the things that you should know about. CVS. Suppose you explain to the patient that she needs to undergo a CVS and you tell her that it is an invasive test, right? So patient डर जाती है. Patient कहती है, oh doctor, I don't want to undergo a invasive test. Is there any other option for me? So can you tell her something? Is there any alternative? If patient currently does not want to undergo a CVS, alternative if the screening is positive. So ideally, yes, she should undergo a CVS, but if she is scared or if she refuses, then what will you do? Then the alternative here is one of the newer tests which is called as NIPT, okay? Non-invasive prenatal test, right? What is the other name for non-invasive prenatal test? The other name is cell-free fetal DNA test, right? So cell-free fetal DNA test, right? As the name suggests, it is non-invasive. So what do? We are going to take a sample of maternal blood. But this can be done only at and beyond 10 weeks. So you're going to take a sample of maternal blood at and beyond 10 weeks. What is the concept behind this? The concept is that all pregnant women have cell-free fetal DNA circulating in their blood. Right? So all pregnant women have fetal DNA circulating in their blood. Right? So what we can do is we can isolate this part of the fetal DNA and we can do a test on it. Right? What is the advantage? Advantage is that it is non-invasive. Yes? And it has a very high sensitivity as well. Close to 99%. So it has a very high sensitivity. Yes, that's the advantage. It is non-invasive. That is another advantage. Yes? And before I go any further, what do you think is the source of this fetal blood, fetal DNA? Kahan se raha hai? So this is coming from apoptosis of placental cells. So when the placental cells undergo apoptosis, they will release the fetal DNA into maternal circulation. Let me ask you, what is the clinical significance of knowing this? Let me see कौन बच्चा पिक कर पाता है. इस बात से क्या और चीज पता लगती है? Tell me. So this is still placental cells. Yes, it is still a screening test. So please remember, this is a secondary screening test. It is not a diagnostic test. Yes, so it is not a diagnostic test, it's a secondary screening test. Why do we call it secondary? क्योंकि पहले हमने एक प्राइमरी स्क्रीनिंग टेस्ट किया, वो जब पॉजिटिव आया, देन वी आर डूइंग दिस टेस्ट. नाउ लेट मी सी इफ एनीबडी कैन आंसर दिस क्वेश्चन. चलो, अभी बहुत दिनों देर से किसी ने आंसर नहीं किया है, सो यू हैव टू आंसर द क्वेश्चन. टेल मी, if it is having such high sensitivity, yes, and it is non-invasive, why are we not using it as a primary screening test? Why are we using it as secondary? Batao. What do you think is the reason behind this? So, currently, this is a very expensive test. And therefore, cannot be done as a primary screening. The test itself can cost 20 to 25,000, alone. So not every woman has that kind of money to undergo such a screening test. She will say, rather, I don't want to do it only. Yes, so it's a very expensive test. Also, please understand, it is still screening, it's not diagnostic. So if this test turns out to be positive, then your patient has to undergo a diagnostic test. Good. Good, Darshit and Namita. Amar as well, Palak as well. Good. Right? So then she has to undergo diagnostic test. Okay? The second drawback of selfie fetal DNA is that currently this test does not tell us the entire karyotype of the baby. Currently, this test tells us only about trisomy 13, 18, 21 and monosomy X. So it doesn't give us the complete karyotype. Okay. It gives a restricted karyotype. The third thing that you have to know is there is a slight delay in report. It can take up to 7 days for the report to come, right? So there is a slight delay in the report. It could take up to 7 days. It's a range of 4 to 7. Different labs give different timings. Yes. So it is expensive and it gives a restricted karyotype. Yes. So this is what is latest in terms of Downs screening. Is it clear to everyone? Okay. So this is things that you should know with respect to Downs screening in the first trimester. Just because I want to do everything at one place so that you don't get confused, what if your patient's first visit is in the second trimester? So next patient in our OPD, okay, has her first antenatal visit in second trimester. Let's say she is coming to us at 15 weeks. So this next patient, it is a growing tissue, beta. It is a live tissue. It keeps replacing itself. Sanskriti, you should know that even your cells undergo apoptosis, but you are living, yes, and you keep surviving. So this is the this is how homeostasis is. So all your cells, Sanskriti, are undergoing apoptosis at some rate. Okay. It is diagnostic because most of the times the placental DNA is same as fetal DNA. Rarely, I said, don't think of rare things at the first go. Okay, rarely, yes, there may be placental mosaicism, but most of the times the placental and the fetal DNA are the same. Okay, chalo. So now the next patient in your antenatal OPD, let's say is, I'm going to write this. She is a 25-year-old woman. She is a primi gravida. Right? You have done all the things that I have taught you so far. So जो भी मैंने अभी तक सिखाया वो आपने कर दिया. Now you are going to tell me, will you advise her for down screening or no? So there could be different options. You know, you will say, you don't need a screening because you're only 25 years old. The second option would say, you don't need a screening because you've missed the time, you're already in the second trimester, you don't need to undergo the screening. So what do you do? Tell me. What is going to be your advice to the patient? Can she still undergo any screening, or she doesn't need it, or she can't undergo? Jaldi jaldi answer karo. The patient is waiting. So what do you tell to this patient? That she should undergo screening. So even if she comes to you in the second trimester, even if she is 25 years of age, you have to advise it. She may get it done, she may not get it done. That is her decision. Okay. So what test will you offer her now? So now you can't do a combined test and you can't do an ultrasound for nuchal translucency. So what test are you going to do now? So the test that we do now is called as quadruple test. Okay, it's called as a quadruple test, right? So it is a test which is a maternal serum test. Right? So just like we talked about the dual test, this is the quad test. The quad test is called as quad, and I told you yesterday and I said don't worry, I'll tell you tomorrow. Okay, so quad test has 4 components. What are the 4 components that we are going to measure? We are going to measure HCG, we are going to measure AFP, alpha fetoprotein. What else? UE3. कल पढ़ाया था. What was E3? It is estriol. So this is unconjugated estriol. U here does not stand for urinary estriol. Don't get confused. Okay. And what is the 4th test? The 4th test is inhibin A, not B. It is inhibin A. What will be a screen positive? A screen positive is when HCG is more than expected, alpha fetoprotein is less than expected, UE3 is less than expected, and inhibin A is again more than expected. So there are only 2 tests which turn out to be more than expected, which is HCG and inhibin A. Yes? So this is also, please again, this will only tell you the risk of downs. And just like the dual test, the risk will also consider maternal age. So when they are calculating the risk, they will also consider maternal age. Okay? And it is again a screening test. When should she undergo? This test can be done any time between 15 to 22 weeks. So it can be done anywhere between 15 to 22, but generally we would want to do the test before 20 weeks, right? So generally we want to do the test before 20 weeks, yes, but it can be done up to 22 weeks. All right. Anjali is asking, ma'am, triple test nahi karana hai kya? So Anjali, you are the treating doctor of this patient. You are her obstetrician. Yes, you have to write the test for her. Tell me, which one are you going to write? Are you going to write quadruple test? Are you going to write triple test? Are you going to write both the tests? Or you will say, go get any of them done. So Anjali, option A, quad कराएंगे. Option B, triple कराएंगे. Option C, दोनों कराएंगे. Option D, we will give a choice to the patient. She can do inky, pinky, ponky and get any one done. So कौन सा कराएंगे? Quad test कराएंगे. क्यों? Quad test has a much better sensitivity than triple test, Anjali. सो अब हम ट्रिपल टेस्ट नहीं कराते क्योंकि उसकी सेंसिटिविटी कम है, राइट. सो वी वांट टू डू द क्वाड टेस्ट जिसका सेंसिटिविटी अगेन रीचेज अराउंड 80%, right? So preferably we want to do the quad test, right? That is why I first made you write कौन सा कराना है, quad कराना है, ठीक है. Now triple test क्या होता है? So as the name suggests, triple test will have only 3 markers. So in the triple test, we use HCG, alpha fetoprotein, UE3, but we will not use inhibin A. Okay, we will not use inhibin A. Yes, so you should know what is the difference between a triple test and a quadruple test. All right. Then please remember the findings will be the same. HCG will be higher and these two will be lower than expected. Yes, so these two will be lower than expected. Okay. Okay. Please remember triple test is also called as BART test or Kettering test. Okay. So those are the other names, BART and Kettering. Okay. But most popular name is triple test. Right. Okay. Now if the patient turns out to be high risk, what should you do next? So if your patient turns out to be high risk in the quad test, so she is screen positive, which means high risk. What should you do next? So again, she now has to undergo a diagnostic test. Yes? So she now has to undergo a diagnostic test. Which diagnostic test will you do now? You again have to get a karyotyping done to get so you have to need the tissue. So again we need the genetic material of the baby so that I can do the karyotyping. And how do I get the genetic material in the second trimester? So in second trimester, karyotyping will be done by using what? Amniocentesis. Okay, amniocentesis. Now again I'm going to go back to the image, and it is again an image from your concept book itself. Okay, this is what is amniocentesis. So it is again a ultrasound guided procedure. It's not a blind procedure, but this time your needle is going to be in the amniotic fluid and you're going to aspirate the amniotic fluid, right? कितना निकाल लूं? 1 लीटर? कितना amniotic fluid निकालूं? 1 लीटर निकाल लूं? So no, right? So please remember the maximum we need for the test is 20 ml. We don't need more than that, right? So maximum we need is 20 ml. When do you do this? It can be done any time beyond 15 weeks. But most commonly it will be done between 16 to 18 weeks. Why? Because this is the most common time we are doing the quad test. So ज़्यादातर हम लोग quad test भी 16 to 18 weeks में ही करते हैं. So that is why most commonly amnio will be done between this time. Okay. Please remember, we will not do amnio between 11 to 14 weeks. This is something which is called as early amniocentesis. Okay, early amniocentesis, but this is too dangerous for the baby. There is a very high risk of fetal loss in early amniocentesis. So इसलिए अब हम early बिल्कुल नहीं करते. We will do it between 16 to 18 weeks and then it is very safe. Okay, so it is very safe beyond 15 weeks. Okay, how safe? The fetal loss rate will be less than 0.5%, right? So the fetal loss rate will be less than 0.5%. It means, is it more safe than chorionic villus sampling or less safe? It is more safe. Yes. Is it less reliable or more reliable than chorionic villus sampling? This is more reliable, because this is directly fetal cells, so it is more reliable. What fetal cells are we picking up? We are picking fetal amniocytes, or we are picking the dermal fibroblasts. Okay, so बच्चे की skin से fibroblasts निकल के गिरते हैं, and they will be in the amniotic cell, amniotic fluid. So we will be doing the test either on the amniocytes or on dermal fibroblasts. So no Riya bacha, it is more reliable. All right, it is more reliable. It is more safe. Yes, but what is the drawback? Drawback? It can take more time for results. So results will take 7 to 10 days. Some labs can go up to 14 days. Yes. So the result can take 7 to 10 days. Can you think of the reason why? Because these cells are not dividing. They are not dividing. So these cells have to be cultured. And culture takes time. Whereas chorionic villus mein kya tha? They were dividing cells. So they don't need to be cultured. Yes. So the result can take up to 7 to 10 days, sometime 14. Now let me ask you, and here I want you all to integrate your pathology here. If I want faster results, what can I do? Suppose I have sent my patient sample to you, okay, and I am asking you, please give me quick results, okay. So when I say faster results, within 72 hours, how will I get quicker results with the same procedure? Can you think? So here the lab people will have to use better technology, and the way they can do is by using fish, right? So the laboratory can use the fluorescent in situ hybridization, and they can give me faster results as well. Okay, but remember, fish will again not give complete karyotype. Yes, it will definitely tell you that there is downs or there is no downs, but it doesn't give you the complete karyotype. It gives you again the restricted karyotype. देखो जल्दी चाहिए तो पूरा result नहीं मिलता. Most important part of the result मिल जाता है. Is this clear to everyone? Yes? Okay. So these are the things that you have to know about amniocentesis. Okay. Now there is another picture in your concept book, right? This is called as pubs. Okay, so it's again a picture from your concept book. You can write the points there if you want. There are not too many points for this. Pubs is percutaneous umbilical blood sampling. This is the other name for chordocentesis. Yes, so this is the other name for chordocentesis. So if you see, we are taking a sample from the fetal blood vessels, right? So we're taking it from the umbilical cord and we're taking it from the fetal blood vessels. Can you tell me which vessel are you going to choose? So we are going to choose umbilical vein. There is something that I told you yesterday is the reason for this. वो कल factual था. You remember I asked you, fetal blood vessels are high pressure vessels or low pressure? And then we did it कि वो low pressure होती हैं. Yes? And then I asked you, low ज़्यादा किस में low होता है? Artery में ज़्यादा low होगा या vein में? So the umbilical vein has even less pressure. So chances of bleeding will be less if you take the sample from umbilical vein. Yes, whereas chances from bleeding will be more if you take it from the artery. So we're going to take it from the umbilical vein. Can you see what part of umbilical vein are we using? So we are not using the end which is attached to the fetus. We are not taking the sample from the middle free loop. We are taking the sample from the placental end of the cord. Yes, so we are taking a sample from the placental end of the cord. Can you think of the reason why? Because this will be the most stable part of the umbilical cord, right? Middle free loop to hilta rehta hai, so it's very difficult to target it. And if you take it to the fetal side, you may injure the baby. So we will take the sample from the placental end of the cord. Yes. What do you think? Is this procedure more risky than amnio and CVS or less risky? Definitely more risky. The fetal loss rate is as high as 3%. So it has the highest fetal loss rate. So it means if you want to do a diagnostic test for Downs, yes, will you prefer amnio or will you prefer pubs? Definitely amnio. Okay, definitely amnio. When can you do this? This can be done beyond or equal to 18 weeks. Yes, so as early as 18 weeks. Not earlier than that, then the fetal loss rate will be even more high. Okay, so this is what you should know about pubs. You should just know that yes, it can be used for karyotyping, but not used. Okay, so but not preferred because it is the most dangerous of the three procedures. Yes, is this clear to everyone? Okay, so these are the things that you should know about Down screening and diagnosis. But before I go any further, there are some factual things which actually come from pathology and you should know that about Downs. I'm just doing a quick recap and a recall for you. I want answers from all of you. Come on, come on. तुम लोग सो गए या जाग रहे हो? सो गए या जाग रहे हो? So come on, everybody needs to be attentive and active. So quickly tell me. You all know that Downs is trisomy 21. Who is going to tell me the most common cause of Downs? Pathogenesis. Can you tell me? What is the most common cause? It is what? It is something that happens by chance. Yes? So it is something that happens by chance at the time of cell division. Right? So 95% of times, okay, it is something that is happening by chance. Right? और क्या बोलते हैं उसको? जल्दी बताओ. Anybody? Anybody? Okay. Tell me the clinical significance of this. Once I am saying that 95% of cases are happening at the time of cell division by chance, what is the clinical significance? Yes, I was waiting for this. Good, Palak. So, path ko वापस निकाल के लाओ. So, it is non-disjunction. Good. Yes. So, non-disjunction. So, what is the clinical significance? The clinical significance is that most cases of Downs, 95% of times, it is not inheritable. Okay, so 95% of times it is not inheritable. But yes, the remaining 5% can be inheritable. The remaining 5% can be because of translocations. Okay, so Robertsonian translocations, or it can be because of mosaicism. ठीक है? What is in general the recurrence risk of Downs? Can you tell me? In general, what do you think will be the recurrence risk? So answer is very simple. The answer is whatever is the risk in general population. Yes, because most of the times it is not inheritable. So this is around 1%. But in which condition does the recurrence risk increase? If there are translocations. Yes. Now, the recurrence risk in case of translocations depends on what? Can you tell me? Depends on what? Depends on number one, who is the carrier, and number two, what is the translocation? Yes? So if mother is the carrier, then the risk is up to 10%. Right? So if the mother is the carrier of the translocation, then the risk is up to 10%. If father is the carrier, then the risk is up to 4%. Right? Then the risk is up to 4%. What do I mean by type of translocation? So this risk will be true if the translocations are like this: 1321, 1421, 1521, and so on. So if this is the kind of translocation, the risk is 10% if the mother is the carrier and 4% if father is the carrier. But, okay, now comes the big but. The big but is, if translocation is 2121, who is going to tell me then what is the risk? Jaldi batao. Go back to your pathology and tell me. If translocation is 2121, then what is the risk? Then the risk is 100%. Okay, then the risk is 100%. Alright, how will we ask you the same thing in the exams? So let's call the next patient in our OPD. So next patient, please come in. Yes. So what is the next patient? Next patient is a woman who says her first child was Downs. She has got herself evaluated and she is a carrier of translocation 2121. Yes, so this is a patient who is pregnant for second time. Yes, so this is a patient who is pregnant for second time and her first baby had Downs. She is a carrier of 2121. Can you tell me what is the advice that you want to give her? You should definitely discuss MTP with her. Yes, so yes, you should definitely discuss MTP with her. On the other hand, in another MCQ, if I tell you that she has translocation 1321, now what is your advice to the patient? Now my advice is that she needs to undergo prenatal testing. Yes, so she needs to undergo prenatal testing, and depending on the result of prenatal testing, she may continue with the pregnancy, she may undergo a MTP. Yes, do you understand how relevant pathology becomes now? Yes, do you understand? So something that is core pathology, but we are using it here in a clinical format. Yes, so with this we do some of the factual things in Downs that could be asked in a clinical format. Okay. Also, as an advice, this is something that I have to tell you. If first baby is Downs, the preferred test in the next pregnancy is, Okay, the preferred test in the next pregnancy is which one? It is diagnostic test. Right? Screening can also be done. So we are not saying that screening test cannot be done. But you tell the patient that it is better that she straight away undergoes a diagnostic test. If she says, no, I don't want to undergo an invasive test, then yes, you start with the same screening protocols that I have taught you, depending on whether she is in the first trimester or whether she is in the second trimester. Yes, now let us quickly look at some of the cases that we have here. Okay. Let's look at this. So she is a 30-year-old patient who presents at 10 weeks for her first prenatal visit. She has a 29-year-old friend who had a baby with Downs. She is concerned about her own risk of having a baby with the same problem. Which of the following tests will you offer her? Riya, amnio is diagnostic बच्चे. Anything which you are using to know the karyotype is diagnostic. So CVS, amnio, Cordo, they are all going to be diagnostic. Okay, because they are giving you the genetic material for karyotyping. Okay. So yes, so she is still in the first trimester. So triple out हो गया, quadruple out हो गया. Which is going to be better, combined test or only the dual test? Obviously, the combined test. The combined test is the one which has more sensitivity. Dual test alone is not good. So you should be doing a combined test. Yes, is it clear to everyone? Okay, so you should be doing a combined test, right? Let me see if I have another one. Let's look at this. The patient above got the screening done. So मेरे कहने पे उसने screening करा लिया. She comes back to you because her NT scan shows a value of 3.5 mm. What is the next step in her evaluation? Yes, so what do you want to do? So she is 10 weeks. What do you want to do now? So do you offer her a diagnostic test? Do you ask her to come back for a repeat ultrasound? Do you say, okay, हम second trimester में दोबारा से test करेंगे और फिर देखेंगे? या फिर we will complete the first trimester testing and then we will wait for the risk. What do you do? So उसने अभी blood test नहीं कराया है. She is coming to you with an NT and she is saying, oh doctor, it turns out to be 3.5. The radiologist said, go and meet your obstetrician. What would you do? The answer is A. NT is a strong associated factor for aneuploidy. Please remember this. Once NT is more than or equal to 3 mm, चाहे अभी serum test हुआ है या नहीं हुआ है, your patient must undergo a diagnostic test because NT has a strong risk of Downs. It's not confirmatory, but the association is strong. Yes, is it clear to everyone? Yes. So, do you see whatever values you are learning? I keep saying this. Some values are important because that is what is going to help us in clinical situations. So, जो values मैं class में दे रही हूँ, वो values important हैं, चाहे next हो, चाहे NEET हो, चाहे कोई भी exam हो. Okay, it doesn't matter what the name of the exam is. Yes. So this is what you are going to do. Okay, right. So with this we finish things that you are going to tell her in the first trimester, right? And you have asked her to come for follow up. Yes. Do you want a little break now? Do you want a short break? Yes. So, how much do we do? Do we take a 15-minute break? So, we will come back and we will see some of the important things that we need to know if patient comes back to us with certain complaints. Yes? So, is a 15-minute break good? Okay. Okay. Quickly tell me, do you feel good about concept building in the class? Yes or no? No. Sanskriti? Beta, 40 weeks fixed hai, magar that is, what you are calculating is for a 28-day cycle. So the Naegele's formula is for a 28-day cycle, right? So when you talk about fertilization in a 3-week cycle, it is happening 1 week earlier, okay? It is happening 1 week earlier because the luteal phase is constant, okay? So last 14 days is always constant. It is the first half of the cycle that varies. So इसका मतलब ovulation भी 1 हफ्ता पहले हो रही है और fertilization भी 1 हफ्ता पहले हो रही है, ठीक है? चलो, so we will take a 15-minute break. We will restart the class at 7:45. Okay, we will restart the class at 7:45. All right, so let's go back to what we were doing. Yes, Srishti, as I taught you yesterday, that progesterone is a smooth muscle relaxant, right? And yes, estrogen increases the contractions. Okay, we will talk about that when we talk about parturition or the onset of labor. Okay, chalo. Now, till now we have done that everything with our patient is normal, hai na? She came to us for her first visit, right? So she came to us for her first antenatal visit. Everything is normal. Yes, we are calling her now at 11 weeks. Yes, so we are now calling her at 11 weeks, where we want her to undergo the ultrasound and we want her to undergo what? We also want her to undergo the serum test. Yes, and probably also it's time for her to get the second injection TD. Yes, so probably it's also time for her to get the second injection TD. Now, the reason I wanted to write this is, yes, we are going to do an ultrasound and we are going to look for nuchal translucency. But what else do we look for in the first trimester ultrasound? Yes, देखो वो आई है अल्ट्रासाउंड कराने, आप खाली एंटी लिख के तो वापस नहीं भेज दोगे ना. सो फर्स्ट ट्राइमेस्टर अल्ट्रासाउंड और क्या क्या चीजें देख सकते हैं, एंड इट्स इंपॉर्टेंट एज वेल इन द फर्स्ट ट्राइमेस्टर स्कैन. सो वन वी नो इज एनटी. Other that I taught you was gestational age assessment. That is also done best in the first trimester. है ना? Right? What else can you tell me do we need? We also need, if at all, अभी तक तो हम normal pregnancy पढ़ रहे हैं, अब हम धीरे धीरे patient की complaints पे जाएंगे. So, if there is any doubt about whether the pregnancy is intrauterine or extrauterine, वो भी किस पे पता लगता है? Ultrasound. So, it also confirms location of pregnancy. Yes, whether it is intrauterine or extrauterine. Very importantly, it will also confirm about the viability of pregnancy. Yes. So why do we say that? Because this is the time that we are going to look for cardiac activity as well. Yes, you all know I taught you when earliest you can see. So you can always get to know about whether the baby is alive or not. So this is where we will use ultrasound also for abortions. We will talk about it. What else is very important? Number of fetus. Yes, so right in the first trimester itself, you should know whether it is a singleton pregnancy or a twin pregnancy or a triplet pregnancy. Yes, so number of fetus is also very important. Okay, and if it is a multifetal pregnancy, then first trimester is also the best time to know about chorionicity. So in case of multi-fetal pregnancy, the first trimester ultrasound is also the best time to look for what? To look for chorionicity. Yes, then it will obviously you can start commenting upon the placenta, right? And we are always concerned about placental location. Yes, so these are some of the things we want to look for along with nuchal translucency when I am doing a first trimester ultrasound. Yes, now ये सब था जब पेशेंट हमारे पास अपनी रूटीन विजिट के लिए आई है, राइट? Now maybe when she comes to you for her routine visit, the patient may have some concerns. Yes, she may have certain complaints that she wants to talk to you about. She may have certain symptoms that she is worried about. Yes, so now it is the duty of the doctor to let her know whether this symptom is worrisome or this symptom is not worrisome. So although we have told her about the warning signs, she may be a patient who is more worried about things happening in her body. Yes? So now let's call the next patient to our OPD and let's see what she is going to say. Yes? So the next patient who comes to your OPD is a 8 weeks pregnant patient, right? So she is an 8 weeks pregnant woman and she is complaining of nausea and vomiting. Yes? So tell me, what are you going to tell her? She says, doctor, I am not able to eat anything. Okay, I have a lot of nausea and vomiting. I am not able to eat anything. What are you going to tell her? So this is the first thing that this patient is saying, that I have a lot of nausea in the morning, I can't eat anything. What will you tell her? So definitely you have to tell her that this is physiological. But if you just tell her this and ask her go away, it is physiological, she will not be happy about it. So what is your advice to this patient? Tell me, what is your advice to this patient? The first thing your advice is that she should begin dietary changes. Okay, so she has to begin certain dietary changes. What does it mean? You have to tell her that she should not be taking big meals. She should be taking small meals every 2 hours. So instead of taking a big meal in the morning, afternoon and evening, ask her to take small frequent meals. Yes, that is the first thing. You ask her to avoid certain triggers. For example, the trigger can be spicy food, it could be acidic food, it could be a high fat food. These are some of the known triggers, right? Also tell her that fluid should be consumed. Okay, so fluid should be consumed 30 minutes before or 30 minutes after a meal to prevent fullness. Yes, so the fluids should be consumed 30 minutes before or after. Right, so these are the dietary changes you advise her. But now the patient comes back and say, no doctor, these dietary changes that you have told me, they are not helping me. I am still not able to eat anything. Then what do you do? So this is when you will start her drug therapy. Yes, so if the dietary changes and avoidance of triggers is not helping her, now you will ask her to start the drug therapy. So quickly tell me, what is the first line drug? It is going to be pyridoxine, right? So B6. So pyridoxine is the first line drug. 10 milligram OD is what is given. If the patient shows no response to pyridoxine alone, yes, then you will combine pyridoxine with doxylamine. That is also 10 milligram. So one tablet will have 10 milligram of pyridoxine and 10 milligrams of doxylamine. Yes, so that is the drug that you will then give. And if this also doesn't help, then you go on to antiemetics like prochlorperazine, promethazine, right? So then you switch over to antiemetics, right? So you should know the basic treatment. More and more, the NEET PG questions are going to be about the basics and what is going to be your advice to the patient, right? Now from this, I'm also going to go further and ask you, nausea and vomiting is physiological. I have told you how to manage that as well. But how will you know whether this nausea and vomiting is severe, to be called as hyperemesis gravidarum? Right? So when or how will you decide that this is no longer just, simple nausea and vomiting? This is hyperemesis gravidarum. Okay, so this is typically a diagnosis when the nausea and vomiting are so severe that they cause weight loss. So when nausea and vomiting cause weight loss of more than 5% of pre-pregnancy weight, and they cause ketonuria. So ketone bodies in the urine is not normal. So if this woman who has nausea and vomiting, it's so severe that it is causing ketonuria and weight loss, that's when you will say that it is hyperemesis, right? It is more commonly seen in praemie gravida. Okay, do you know which hormone is mainly responsible? So hormone which is mainly responsible for hyperemesis is HCG, but estrogen and progesterone also contribute, right? So the main hormone is HCG, but estrogen and progesterone. All right, I hope it is back for all of you. So there was a transient problem. Again, I just had to switch off and switch on everything. Is it back for everyone? Is it back for everyone? Am I there? I will repeat. Yes, I will repeat. Okay, right. So yes, I was talking about when would you say that this nausea and vomiting of pregnancy will be labeled as hyperemesis. So what I said was that when the nausea and vomiting are so severe that it causes weight loss of more than 5%, right, and it causes ketonuria. Right, that's when you start labeling it as hyperemesis gravidarum. Okay, then I said that it is more common in praemie gravida. Okay, now remember that the main hormone responsible for this is HCG, right, but estrogen and progesterone will also contribute, right? So estrogen and progesterone would also contribute. Now if the main hormone is HCG, can you tell me when would the symptoms be maximum? Yes, can you tell me when would the symptoms be maximum? So the answer would be around 10 weeks. The peak symptoms would be at 10 weeks. Who is going to tell me why? Because this is the time when HCG also peaks. Yes, so this is the time when HCG also peaks, and after that it will start reducing. The symptoms will start improving. Yes, so any other risk factors apart from, yes, the hormones are the main cause? H. pylori, right? So H. pylori infection is known to be a risk factor for hyperemesis gravidarum. Yes, is it clear to everyone? Now, what is the clinical implication of hyperemesis, right? Or what is the clinical significance of hyperemesis gravidarum? So the first thing is, if this woman is going to have so much of vomiting and she is not able to eat or drink anything, it would cause electrolyte imbalance in the patient. Yes, it would cause electrolyte imbalance in the patient. Yes, very, very important, and I'm sorry I forgot. I have to write the other risk factors also. I just wrote one and I forgot to write the others. So apart from H. pylori infection, write these two as well. So multi-fetal pregnancy and presence of a female fetus, as well as molar pregnancy, right? So we have seen the risk factors to be H. pylori, but apart from that, it can be multi-fetal pregnancies because the HCG levels will be high. Molar pregnancy, again, because the HCG is very high in molar, and if the female is carrying a female fetus. So these are known associations of or risk factors for hyperemesis gravidarum, right? So coming to what is it going to do for the female? So number one, it can cause electrolyte imbalance, right? Second, it can cause liver function abnormalities, okay? It can cause liver function abnormalities. Third, it can lead to features of hypovolemia. Yes, so it can lead to hypotension as well, right? So it can cause hypovolemia. Remember what it is going to cause? It is going to cause metabolic alkalosis. Okay, it is going to cause metabolic alkalosis. Sanskriti, हर चीज का कई बार why नहीं होता, but here probably it is because of the more estrogen levels in the body if it is a female fetus, since hyperemesis is mainly linked to hormones. ठीक है? But a lot of times the sex may not be completely explained and why it has a probability of something and not of the other. But here it is probably because of higher levels of estrogen. Okay? Right. Then please remember, when I say it can cause metabolic alkalosis, yes, the reason here is that she is vomiting out the gastric secretions, right? So she is vomiting out the gastric secretions. It can cause hypochloremia. Very, very important. It can cause hypokalemia, right? So hypochloremia, hypokalemia and ketosis. These are worrisome things, right? So these are worrisome things, right? So remember, these are the possible lab abnormalities that you can get in a woman with hyperemesis gravidarum. Okay, now what are you going to do for her as a part of management? Now, before I go on to as a part of management, there are two important complications that you should know that are associated to this. So one is Wernicke's encephalopathy, right? And this is because of deficiency of thiamine in these women. So hyperemesis gravidarum is linked to Wernicke's encephalopathy. Something that maybe could be asked as a part of neurology, right? So they could combine this Wernicke's encephalopathy and a pregnant woman and ask you the cause. So remember this. The second thing which they could relate it to is Mallory-Weiss tear. Yes, so esophageal tears that you do in surgery could also be linked to hyperemesis gravidarum. So these are the two things that I want you to know as complications that can happen with hyperemesis gravidarum. Okay, now please remember, I have told you the usual treatment of nausea and vomiting. So I said first give only pyridoxine, then give pyridoxine and doxylamine. If it is not getting treated, go on to antiemetics like diphenhydramine or dimenhydrinate, metoclopramide, promethazine. Yes, but when it comes to hyperemesis gravidarum, okay, when it comes to hyperemesis gravidarum, we would usually start these women on ondansetron or injectable antiemetics, right? You may have to keep them nil per oral, start them on injectable antiemetics or ondansetron, and gradually as the symptoms improve, you will start the, they can start the food intake as well. Is it clear to everyone? Yes. So the usual protocol of pyridoxydoxylamine, then डाइफेनहाइड्रामीन और डायमेनहाइड्रेनेट, राइट, वो प्रोटोकॉल हम यहाँ फॉलो नहीं करते, राइट. दीज पेशेंट्स वुड नीड एडमिशन. They would need stronger drugs like ondansetron or injectable antiemetics. Yes, is this clear to everyone? Okay. So this was how will you know whether you should be worried about the nausea and vomiting of pregnancy, or you should not be worried about the nausea and vomiting of pregnancy, right? Now, let us look at next patient. Okay, I have already talked about some of those findings, so you will quickly recall and tell me. Let us say that our next patient comes to you and says that she feels dizzy, right? So there is dizziness, right? Especially she may tell this with respect to postural change as well. So you all know the reason behind this. So if she is telling you that she feels dizzy, you have to tell her that this is because of the fall in the blood pressure. If she's supine, the blood pressure can go into hypotensive ranges. We've done even MCQs on it, right? Okay. Next, if your patient comes with history of bleeding gums, these are some things which are common and can happen in the early pregnancy. And since these are very new symptoms, the patient could be worried about them. So please remember, bleeding gums in pregnancy is again a physiological thing. There is nothing to worry a lot about it. Okay, the management is completely conservative. Okay, and sometimes these bleeding gums may also be associated with swelling of the gums, right? And this is what is called as epulis. But the most important thing that I feel that you should know, and has been previously asked, that sometimes when you examine these patients, you may see reddish purple exophytic growth on the gum. What is this? So when you examine these patients, you may see a reddish purple exophytic growth on the gum. This is what is called as pregnancy tumor, also called as granuloma gravidarum, also called as pyogenic granuloma. So again, this is not a malignancy. Okay, this is not a malignancy. It's a benign thing. You don't have to worry about it. Do not excise. She does not have to undergo any excision. This is going to subside by itself postpartum, right? So this is physiological, and this is actually made up of granulation tissue. That is why it is called as granuloma gravidarum. Yes? Okay. Next patient, maybe she comes to you and says that she has varicose veins. Yes, so maybe she comes and tells you that she has varicose veins. Obviously she will not use the term varicose veins. She will say that she is seeing prominent veins. Yes, so especially these could also be present in the vulval area, right? So they could be present in the vulval area, but the other places are saphenous and even hemorrhoidal. And sometimes they could bleed, right? So the hemorrhoids could bleed, the vulval varicosities can bleed. So again, this is something that does not need any medical or surgical treatment. Yes, the reason is because of increased blood volume and increase in the venous pressure in the lower limbs, right? So increase in the venous pressure below the pelvis and increase in the blood volume is the reason. So you don't have to do anything additional. You have to tell them that the management is all conservative, like leg elevation. They could wear compression stockings, right? They could sleep on the left side to ensure a good venous return, right? and avoiding long-standing episodes. Right? So avoiding, long-standing durations. So there is no need of any medical or surgical intervention. So, even if they are like vulval varicosities, what she needs to do for them is have a good vulval support and compression can be applied, right? So, she should wear a good vulval support and compression can be applied, but there is no need to actually go and operate on her, okay? Then, the next patient that comes to your clinic says that she is having a lot of leg cramps, right? Something that she was not experiencing before and therefore she is worried. Now, do you know that this is the most recent NEET PG question? Yes? So this is one of the most recent questions, not NEET PG, INI CET. Yes? So this is one of the most recent questions. The reason is again because of accumulation of lactic acid, right? So there is contraction of the muscle. What she needs to do is stretching of the muscles. So stretching the muscle will help. So what she has to do is do a knee extension and do a ankle dorsiflexion, right? So do a knee extension and do a ankle dorsiflexion. Okay? What else you should tell her? Improve hydration status, and she can also do a hot massage in the leg muscles. So she could do a hot massage. She should improve hydration. Sometimes we even ask the patients, they could take a hot bath at night before sleeping, right? So that also helps. So basically you have to ensure at the time of the cramp, what she should do? So at the time of the cramp, she should do a knee extension and ankle dorsiflexion. Yes? Okay? Then, two important neurological things that you should know are physiological or can happen in pregnancy, right? So one is carpal tunnel syndrome. Do you know that pregnancy carpal tunnel syndrome is quite common? Yes. And what is the reason here? That, the median nerve in the carpal tunnel is getting compressed because of fluid retention. So in pregnancy, you all know there is a lot of fluid retention. So because of the fluid retention, the median nerve is getting compressed, right? So can you tell me, where will she have the neurological symptoms? So the neurological symptoms could be in the form of numbness, it could be in the form of tingling, burning, right? So she will have these neurological symptoms. Can you tell me in which fingers? So thumb, index and middle finger. Yes? So thumb, index and middle finger, she can have these neurological symptoms. And yes, carpal tunnel syndrome is quite common in pregnancy. Yes? What is the management? What do you think you're going to do? Are you going to operate? No. Right? Operate is the rarest thing that we will do. So it's rarely done. So what you need to do is give her a wrist splint. So most of the times they can be given a wrist splint and you put this splint in the neutral position or slight extension. So either put it in the neutral position or in slight extension. Yes, so just give her a wrist splint. It will improve her symptoms. Please remember steroid injections, which you may have read otherwise in orthopedics or will read, and surgery are rarely indicated in pregnancy. So don't go and mark the answer as steroids and surgery. Okay, so these are rarely indicated in pregnancy. All right, is it clear to everyone? And another neurological thing which can be seen in pregnancy is Bell's palsy. Okay, it can be Bell's palsy. Why? The reason is again perineural edema, right? And the nerve gets compressed. The other reasons apart from perineural edema are hypercoagulability. I told you yesterday that pregnancy is a hypercoagulable state. So hypercoagulability as well as immunosuppression. So these are the pathogenesis of why Bell's palsy is often seen in pregnancy. Again, no special treatment needs to be done. Okay, most of these women, are going to recover. So what we can do is short term. Please remember, it has to be a short term course of glucocorticoids, right? Which you anyways know is what you do for Bell's palsy. So you're going to give them a short course of glucocorticoids, but just remember that you avoid it during the period of organogenesis. So avoid it during the period of organogenesis. Is it clear to everyone? So these are certain things which you should know are common in pregnancy, and you may face a clinical situation, right? So you should know what is the optimum advice and what you're going to do with the patient. Yes, is this clear to everyone? Okay. Now, our next patient is going to be a little special. Yes? What is she going to be? So let's do our next patient. The next patient who has come to your OPD has come back to you with her baseline investigations. Okay? So she has come back to you with her baseline investigations, or she says that she is, let's say this. Our next patient says that she is 6 weeks pregnant. Yes, so she is 6 weeks pregnant and she is a known case of hypothyroidism. Right? Now this is very important. I also told you when we were talking about high risk pregnancy that hypothyroidism is a high risk pregnancy. Can you tell me why? Why is this something that I want to highlight and I want to specially do it? What do you think can overt hypothyroidism do to the pregnancy? Kya karega? So if we have to know this, overt hypothyroidism has a lot of clinical application in a pregnant woman. Okay? The first thing that you have to know is that hypothyroidism has been specially linked to abortions. Okay? So it can actually cause an abortion. Second, it has been linked to various complications in pregnancy like preeclampsia, abruption, okay, preterm labor, low birth weight in the baby, and yes, something that you all know is what? Cognitive impairment, yes, in the child. Right? So we are very concerned when we talk about hypothyroidism. Now, before I tell you what you should do with a woman who is a known case of hypothyroidism, I have to tell you certain physiological changes that you should know in pregnancy, and then you will understand why we are doing what we are doing. Okay? So the first thing I want you to understand is, if we look at physiology of the thyroid, okay, that in pregnancy there is a major increase in TBG, the thyroid binding globulin. Yes, and this TBG is increasing because of the hormone estrogen, right? The second very important thing that you have to know is that in pregnancy, there is stimulation of the thyroid gland. Right? Now, can you tell me PTL is preterm labor, bache? Okay, preterm labor. It has been linked to preterm labor. All right. So, can you recall and tell me what is the cause of extra stimulus to the thyroid gland? Can you tell me? So, if you remember in the early part when I taught you hormones, I said that the alpha unit of HCG is absolutely identical to the alpha unit of TSH. तो TSH का काम क्या होता है? थायराइड ग्लैंड को स्टिम्युलेट करना. और यहां पे who is doing that? The rising HCG levels. Yes, so the high HCG levels are stimulating the thyroid gland to produce more hormones. So which means if I ask you what happens to total T3 and total T4 in pregnancy, what is the answer? They are going to increase. So total T3 will increase and total T4 will increase, which means there is a balance. Binding globulin भी बढ़ रहा है मगर उधर से production भी बढ़ रहा है, right? So what about free T3 and T4? The net effect is no change. Yes, the net effect of free T3, T4 is no change. And what about serum TSH levels? Again, there is no change. Which means अगर आप सिर्फ आधी information पढ़ते हो, which means if you read only this, that total T3, T4 increase, ऐसा लगता है pregnancy will be a state of what? Hyperthyroidism. Yes, मगर ऐसा नहीं है. Pregnancy is generally considered as a euthyroid state. Right? So pregnancy is generally considered as a euthyroid state. Okay? Now, if I ask you here, what do you think will happen to the iodine demand? Can you tell me? Naturally, the iodine demand by the tissue will increase because it has to make more of the hormones. Yes? So the iodine demand will increase. Do you know what is the RDA of iodine in pregnancy? It is 250 micrograms per day, right? So the RDA of iodine in pregnancy is 250 micrograms per day. Okay? Now, once you understand this, now we will come to hypothyroidism. So now can you tell me, if your patient is a known case of hypothyroidism, tell me what do you understand with this? Do you understand that this means her gland is damaged? Yes or no? And do you understand that this means her gland is not capable of producing the sufficient amount of what? Thyroid hormone. Yes, so this is a damaged gland and it is not able to work properly. So now if I ask you, so you will correlate everything and tell me. If I ask you, your patient is taking hormone thyroxine and let us say she is taking X milligrams prior to pregnancy. Now if she is pregnant and she comes and tells you that doctor, I am a known case of hypothyroidism, what do you think should you do to her dose of thyroxine. सोच के बताना. Now generally you people will say decrease the dose. Yes, tell me, will you decrease the dose, will you increase the dose, or will you sort of continue the same dose? क्या कर रहे हैं? So most of the students think that we will decrease the dose. How do they think? वो बोलते हैं अच्छा HCG is going to stimulate the gland. The gland will anyway produce more, so her dose requirement will go down, which is incorrect. You have to understand that this is a damaged gland. Even if HCG is going to stimulate it, it does not have the capacity to produce more hormone. Yes, do you all understand this? So never write decrease dose. This is very important, bache. Yes, so the dose has to be increased. You don't have to take a medicine referral for this, okay? So just remember, if a woman who is a known case of hypothyroidism conceives or she becomes pregnant, you should increase the dose by 50%, right? So increase the dose by 50%. Can you tell me, or maybe you're not able to tell me, I will tell you, what is the target TSH levels in pregnancy? My goal is to keep TSH less than 2.5. Okay, so my goal is to keep the TSH levels less than 2.5. Okay, is this clear, everybody? Right? All right. Also, I want to ask you here, what is the most common cause of hypothyroidism? So this goes back to your medicine now. Tell me, what is the most common cause of hypothyroidism? Mark it as Hashimoto's. Right? Please don't mark it as iodine deficiency. Okay, so the most common cause of hypothyroidism is going to be Hashimoto's thyroiditis. ठीक है बच्चा? Okay. Now, coming to hyperthyroidism. Now, इसमें बहुत ज़्यादा चीजें नहीं है. The moment you say hyperthyroidism, you have to know that the most common cause is Graves. Even in pregnancy, the most common cause is Graves' disease. ठीक है? The most common cause is Graves' disease. All right? And when it comes to the drug of choice, which is what we ask you, okay, the drug of choice in the first trimester is propylthiouracil, whereas the drug of choice in the second and third trimester is methimazole. Okay, the drug of choice in the second and third trimester is methimazole. What is the drug of choice for thyroid storm? What is the drug of choice for thyroid storm? The thyroid storm is also PTU. Okay, the drug of choice for thyroid storm is also PTU. संस्कृति बेटा पूरा टाइम में वही तो समझा रही थी जो आपने फिजियोलॉजी पढ़ी, जिसमें कि थायराइड ज्यादा बन रहा था. दैट इज द फिजियोलॉजी इन प्रेगनेंसी ऑफ अ नॉर्मल ग्लैंड. जब ग्लैंड ऑलरेडी डैमेज्ड है तो वो प्रेगनेंसी हो या प्रेगनेंसी ना हो और ज्यादा कहां से बनाएगा, राइट? सो प्लीज अंडरस्टैंड द फिजियोलॉजी इज व्हेन द ग्लैंड इज नॉर्मल, बट वंस यू आर सेइंग इट इज hypothyroidism, it is a damaged gland beta. It will not be able to produce more. So to keep the requirements of pregnancy, you will have to give the dose from outside. Okay? हाँ, पलक यही सिखाना है. प्रोपेनोलॉल सिर्फ सिम्टम रिलीफ के लिए है, ठीक है? वो सिर्फ टैकीकार्डिया को ट्रीट करता है बेटा. विल इट ट्रीट द कॉज? है ना? सो प्लीज रिमेंबर, थायराइड स्टॉर्म में पहला ड्रग जो आपको यहां पे देना पड़ेगा वो PTU है, ठीक है? प्रोपैनोलॉल आप टैकीकार्डिया जैसे सिम्टम्स को मैनेज करने के लिए देते हो. इट डजंट ट्रीट द कॉज. इज दिस क्लियर? राइट. ऑल्सो कैन यू टेल मी these drugs, whether it is PTU or whether it is methimazole, do they cross placenta? Yes. Okay. So these drugs can cross placenta. Yes. So they can cross placenta. And what can they do to the baby? They will go and attack the fetal thyroid gland. So they can cause fetal hypothyroidism. But these drugs are usually safe. More safe is PTU. That is why it is the drug of choice in the first trimester. What does methimazole exposure in the first trimester do? Can you tell me? अगर आपने कहीं और पढ़ा हो, let me give you a hint. शायद आपने dermatology में पढ़ा हो. What does methimazole exposure to the fetus do? So, aplasia cutis. Yes, it can cause aplasia cutis. So, methimazole should not be given in the first trimester. Is this clear? Okay. Also, please remember, if it is a thyroid storm, I am saying the drug of choice is propylthiouracil. Can you give radioiodine? Can you give radioiodine? Absolutely a big no. Okay. So please remember, radioiodine is contraindicated in pregnancy. Never ever give radioiodine for ablating the gland. Is this clear? Yes, बच्चे? Clear हो गया? All right, perfect. ठीक है. Now, there is, so this is some very basics of early pregnancy that you should know. अभी तक हमने कुछ भी abnormal नहीं किया है. हमने सिर्फ ये देखा है कि कौन कौन सी normal physiological चीजों के साथ the patient can come and present to us. Yes, agreed? Yes. So far what we have done is, how would a normal pregnancy start? What can be the concerns of normal pregnancy in a woman? What should you know that is normal? Because only then you will be able to pick up abnormal. And if something is worrying your patient, how will you advise her and how will you manage her? Right? And what should be the routine investigations that your patient in the first trimester must undergo? Is it clear? Now, once we have done with normal, we are now going to move on to a new set of patients. Okay? So this new set of patients is going to come to us with some new complaints. Yes? So let us see what is the next patient in the OPD coming to us with, right? So let's call the next patient. So what is her complaint? We will see. So the next patient that is coming to us, let's say, is a patient who has 6 weeks amenorrhea. Okay, so she has 6 weeks amenorrhea and she is coming to you with bleeding. Right? So she says that she is having bleeding. This bleeding may be light in the form of spotting, it may be moderate, it may be a major amount of bleeding as well. Right? So what all are you going to think of when this patient in early pregnancy comes to you with bleeding? Let me see. What all do you want to think of when she comes to you with bleeding in the early pregnancy? So, This patient could be a case of abortion. Yes. It could be a case of ectopic pregnancy. It could be a case of molar pregnancy, right? So it could be abortion, it could be ectopic, it could be molar, it could be local causes. Yes, by local causes I mean something that can be at the level of the cervix. Yes, I will tell you what it is, or as I taught you before, it could be a vulval varices, right? So it could be a local cause. Yes, it can very well be the implantation bleeding. Yes, which is what I also taught you before. Okay. So gradually this is what we are going to do now. So we are going to do a patient who comes to us with bleeding in early pregnancy. What all do we have to think and what all do we have to rule out? Yes, this is what we have to think. Now please remember, implantation bleeding kaise pata lagega? From the history itself. How? Can you tell me? How from the history you will know that it is implantation? So if you see her timing of presentation, it will be 6 to 7 days from fertilization or approximately 20 to 21 days from LMP. Yes, so if you do this calculation and if it is that time, you know it is implantation bleeding. So this is the hint from the history. Yes, so this is the hint from the history. Okay, then what do you think can be the local causes? So if you talk about local causes, it is or can be a cervical ectropion. Yes, what is a cervical ectropion? So let me ask you this. Do you know that the two parts of cervix, there is an endocervix and there is an ectocervix. So do you know that the two parts of cervix have different epithelium? Yes. The endocervix has what epithelium? Columnar. And the ectocervix has squamous epithelium. Yes. So ectropion is eversion of columnar epithelium. So columnar epithelium evert होके बाहर को आ जाता है, which means it is now going to be exposed to the acidic vaginal secretions or pH, I should say. So it is exposed to the acidic vaginal pH. Yes. So cervical ectropion is an eversion of columnar epithelium. Yes, that is why it is called as an erosion, Anjali. Yes, so that is why it is called as an erosion. It looks like a reddened area of the cervix. This is absolutely physiological in pregnancy. Right? So there is no need to be worried about a cervical ectropion. You don't have to do anything. Can it bleed on touch? Yes, it can, but you don't have to worry. Right? So cervical ectropion or eversion of the cervix or a cervical erosion is physiological. Okay? And what else can be a local cause? Those are rare things. Rare things like a cervical polyp. Right? Now, how will you get to know about ectropion and a cervical polyp? So, these are things that you will be able to see on a per speculum examination. Yes. So, these are things that you will be able to see on a per speculum examination. If there is a polyp or there is an erosion, तो local causes per speculum पे आप rule out कर सकते हो. So which leaves us with three major categories. Now, my patient can be ectopic, she can be abortion, or she could be molar. Right? So what I'm going to start first is going to be, what? Is going to be a ectopic pregnancy. Right? So that is what we are going to start with. We will do the details of how it can present. What things do you need to know in the history? What things do you need to know in the examination? Okay? But before I go on to any of this, right, details of ectopic, abortion or molar, please remember a very basic thing. Whenever a patient of bleeding in early pregnancy comes, you should do a PS and a PV exam. Yes? Per speculum मैंने बोला क्यों? To look for local causes. PV exam में क्या देखते हैं? You're going to look at the cervical os. So we are worried about whether the os is open or the os is closed. So look at the os. You can also look at the os on a per speculum examination, but sometimes it's difficult to find out on PS whether it is open or not. So on a PV examination, see if the os is open. See the uterine size. We will look for other things as well, which is what I'm going to talk about in detail when I go on to every topic in detail. But this is something which is very different from when you come across bleeding in later part of the pregnancy. In later part of the pregnancy, I will teach you, do not do a PS, do not do a PV. This is something which is grossly different, okay, from pregnancy, bleeding in later half. In early half, you must do a PS, you must do a PV, and you must do an ultrasound. A combination of these three things, PS, PV and ultrasound, will usually help in making a diagnosis, whether you are dealing with abortion or you are dealing with ectopic or you are dealing with molar. Yes, is this clear to everybody? Tell me, is it clear beta? Then only I will move further. Right? So bleeding in early pregnancy, you must do PS, you must do a PV exam, and you must do an ultrasound exam. Yes, these things should be done for all patients who come to us with bleeding in early pregnancy. I am saying together these three will help you make the diagnosis. Okay, so now we are going to start with individual things and we will side by side keep on ruling out others. Okay, so the first out of these that I'm going to talk about is going to be ectopic pregnancy. Okay, how do you define ectopic pregnancy? Pregnancy which implants outside the uterine cavity. Yes? So, no. Apurva, when we say early pregnancy, we mean the first trimester. Okay? So, when we say early pregnancy, Apurva, we mean the first trimester. When we have to mention between 13 to 20, we call it as early second trimester bleeding. Okay? We call it as early second trimester bleeding. Typically, when we say early, we mean bleeding in the first trimester. Okay? I'm sorry. Okay. So, pregnancy which implants outside the uterine cavity is called as ectopic pregnancy. Right? Now, what do you think is the most common site of ectopic pregnancy? The most common site is the fallopian tube. Okay? The least common site is cesarean scar pregnancy. Yes, this is the least common, followed by a cervical pregnancy, so a pregnancy in the cervix, followed by abdominal. So, the incidence of cervical cesarean scar and cervical pregnancy is less than 1%, whereas the incidence of abdominal pregnancy is 1%, right? Now, when we say that the most common site is fallopian tube, what do you think is the most common site within the tube? Which part of the tube? So, the most common site is going to be the ampulla. Right? Why? Because ampulla is the site of fertilization. So, it is also the most common site for ectopic. The second reason why ampulla is the most common site of, ectopic is because it has maximum number of plicae. Okay. Now, what are plicae? These are like this. Plicae are mucosal folds. अब मुझे बताओ, अगर एम्प्यूला में सबसे ज्यादा ऐसे फोल्ड्स होंगे तो क्या होगा? प्रेगनेंसी कैन गेट ट्रैप्ड, yes, in these troughs, right? So these are the two reasons why ampulla is the most common site, okay? Because it is the site of fertilization and it has the maximum number of plicae. Remember, it is also the widest part. Yes? Alright. Going on to within the fallopian tube, which is the least common site? The least common site within the fallopian tube is interstitial. Or what was the other name for interstitial? Intramural. Right? So interstitial or intramural. Right? So that is the least common site. Remember that this is also the narrowest part of the tube. Okay. Now, suppose it is an ectopic pregnancy. I want you to think what can be the outcome of such a pregnancy which is in the fallopian tube. क्या हो सकता है? So can you tell me what will happen to an ampullary pregnancy? What do you think? क्या होगा? So most common outcome for the ampullary pregnancy is that it will undergo a tubal abortion. Do you understand what is tubal abortion? That the pregnancy will be simply thrown out of the fimbrial end. Okay? The second most common outcome of ampullary pregnancy is if it is not thrown out and it starts to grow there, what is going to happen? It is going to rupture. Although it is the widest part, but fallopian tube is still a narrow structure. You know, when I say it's the widest, do you know what is the diameter? It is 6 mm wide. Only 6 mm. है ना? So, the second most common outcome is rupture. And if it has to rupture, the ampullary pregnancy will rupture around 8 weeks of amenorrhea. Right? So, it will rupture around 8 weeks of amenorrhea. The second most common site of ectopic in the fallopian tube is isthmus. Can you think what will be the outcome of isthmic pregnancy? So the outcome of isthmic pregnancy most commonly is rupture. तो अब मेरी बात ध्यान से सुनो और आंसर करो, okay? If I ask you which is the most common ectopic, the answer is ampullary. But if I ask you the most common ectopic to rupture, then what is the answer? Then the answer becomes isthmic. So the most common ectopic pregnancy to rupture is isthmic. Okay? And this will rupture around 6 weeks. Okay? So remember, it is more narrow, so it ruptures early. Right? Who is going to think and tell me what will happen to interstitial pregnancy. So, it will also grow and it will rupture. But at what POG will it rupture? Can you think of it? At what period of gestation is it going to rupture? Remember, it is the narrowest part. So, will it rupture at 8 weeks, 6 weeks, 4 weeks, 10 weeks? When will it rupture? So, this will rupture, or the pregnancy here can go up to around 12 weeks. Strange. How come? This was the narrowest part. Then how is pregnancy able to go up to 12 weeks? Remember, the interstitial part I taught you is surrounded by smooth muscle fibers. Yaad hai? Kal padhaya tha? So they are supporting this part of the pregnancy and they let it grow to a bigger gestational age. But now what is the problem? This rupture is going to be most dangerous, right? So the one that is going to be most dangerous or life-threatening for my patient is going to be a rupture of interstitial pregnancy. Can you tell me why? Because here it's not just the tube which is rupturing. A part of the uterus is also giving way. So blood loss is going to be much more here, right? So the blood loss is going to be much more and it will be life-threatening. Yes, is it clear to everyone? Okay, so these are very frequently asked things. Now, why should someone have an ectopic pregnancy? So what are the risk factors which predispose a woman to have ectopic? Okay, remember the most common risk factor is pelvic inflammatory disease. I taught you yesterday, anything which will cause adhesions will stop the transport of the conceptus. Yes? But if we ask you what carries highest risk, so there are two different things. More common is PID, but the risk of ectopic pregnancy is highest with either a previous ectopic or a woman who has tubal surgery, right? So the risk is highest when she has a history of a previous ectopic pregnancy or she gives you a history that she's been operated for some tubal pathology, right? These two carry the highest risk, right? So out of these, the numbers are very difficult to tell which one is more and which one is less, but these two carry the highest risk. Okay. Now, the third important things that you have to know are, things like cervicitis will increase the risk because there is inflammation. Inflammation will heal with, fibrosis. Similarly, multiple sexual partners, because they predispose to PID, they predispose to cervicitis, are going to be risk factors. Cigarette smoking is also taken as a risk factor. Then, previous cesarean section is a risk factor. Very important are infertility and assisted reproductive techniques, right? So ART is assisted reproductive techniques. Why did I say that these are going to be important? Because in your long STEM clinical questions, your examiners will give these things as hints, right? So these are the things which will tell you that the question is going towards ectopic. So history of PID, history of a previous ectopic, a tubal surgery, infertility, IVF, they all tell you that this woman is a high risk for ectopic pregnancy. Okay, bacha? Then, the next thing that I want to talk about is more about understanding. Yes, and what is that? That is, what is the effect of contraception? Okay, so now understand, all contraceptive agents are going to decrease absolute risk of ectopic. What do you understand by this? Can you tell me? What do you understand when I say they decrease the absolute risk of ectopic? मतलब total number of ectopics कम हो जाएंगे. Obviously, why? Because contraceptive will reduce the total number of pregnancies. So if the total number of pregnancy goes down, the total number of ectopics also go down. But when you talk about relative risk, which is if a woman is using these contraceptive methods and the contraceptive method fails, yes? So if she is using a contraceptive method and it fails, and then there is a pregnancy because of this failure, then with certain methods, this pregnancy because of failure is a high risk to be ectopic. So what are these contraceptive methods which actually increase relative risk of ectopic pregnancy? So these are tubal sterilization. Why? Because it is a type of tubal surgery. Yes, so if this method fails, it has a very high chance of causing ectopic. Intrauterine devices. Can you think of the reason why? Intrauterine device, if it fails and there is a pregnancy, it actually protects the uterus more क्योंकि ये खुद वहाँ बैठा है. So it does not let the pregnancy to happen here. So that pregnancy can happen elsewhere, right? And the third are, yes, Riya is right, hormone containing contraception. So progesterone only pills or oral contraceptive pills. If they fail, then again there is a higher risk that the pregnancy will be ectopic. And you know the reason why. The reason is because progesterone is going to reduce the tubal motility. Yes? So have you understood the concept behind relative risk? So this concept is that if this contraceptive method fails, then the pregnancy is more likely to be ectopic. So in your exams or for your exams, should you mark them as risk factors or should you not mark them as risk factors? What would you write? So you should mark them as risk factors. Okay, so you should mark them as risk factors. Is this clear to everyone? Okay. Now we talk about how is a woman going to present to us. So if she is a patient of ectopic pregnancy, what are going to be the signs and symptoms? So come on, can you tell me what is she going to present to us with? So this patient can classically come to us with a triad. Okay, the triad is amenorrhea, pain, okay, which is lower quadrant pain, right, and bleeding. So this patient is going to come to us with either the triad, which is amenorrhea, pain and bleeding, or it may not be all three but two of these symptoms, right? So the crux here is whenever you are seeing a patient with pain and bleeding and early pregnancy, always keep ectopic as one of the differentials. Okay, so always keep ectopic as one of the differentials. I will talk about differential diagnosis, but first I want to elaborate on this. Pain. What is the reason for pain? So please remember, pain is a symptom in ectopic for unruptured ectopic as well as ruptured ectopic. I am sure you all know that why a ruptured ectopic is painful, because it causes peritonitis. But who is going to tell me why an unruptured ectopic is painful? Can you think of the reason? Why should an unruptured ectopic cause pain? The reason here is stretching of the fallopian tube. Right? So the stretching of the fallopian tube because of the growth of the pregnancy is the cause of the pain. And therefore, sometimes we will ask you this question. Pain of ectopic pregnancy is carried by which nerve roots? So here it is an indirect question from anatomy. So this is again what is vertical integration. Yes? So here you have to know that the nerve supply of the fallopian tube is T11, T12 and L1. Right? So T11, T12 and L1 is what is the nerve supply of the tube, and this is what is also going to carry the pain of ectopic pregnancy. Right? Okay. Why is there bleeding? Because the decidua is shed off. Right? So the endometrium was getting ready for the pregnancy, but pregnancy hasn't reached it. Yes? The hormones produced are less. They are produced, but the amount is less. The HCG is less. Yes, because the area that the pregnancy is growing is small, it can't grow big. So the decidua is shedding off, or it can shed off, and it can cause bleeding. In fact, sometimes the patient can say that with the bleeding, a fleshy thing was passed out. Although I will teach you later that passage of a fleshy mass could mean abortion, but that could also happen here, and that is called as a decidual cast. Do you understand cast? Cast जैसे मोल्ड बनाते हैं हम, है ना, मिट्टी से या क्ले से, तो उसी तरह से डेसिडुआ पूरा का पूरा शेड ऑफ हो जाता है, and it is perceived by the woman as a tissue. Right? So sometimes even that can be the history in ectopic. Right? Okay. Coming to what would be the other or can be the other symptoms. The other symptoms could be usual symptoms of pregnancy. For example, she could have nausea and vomiting, which really doesn't help us in making a diagnosis, but she may have orthostatic hypotension. Can you tell me what is the meaning of orthostatic hypotension? So patient says, डॉक्टर साहब जब मैं खड़ी होती हूँ तो मुझे बहुत चक्कर आता है, मैं बेहोश हो जाती हूँ, जब लेटती हूँ तो ठीक लगता है. So which means when she is in standing position, the BP is falling to hypotensive ranges. It gets better when she lies down because the venous return improves. But can you tell me what is the clinical significance of orthostatic hypotension in a woman with early pregnancy bleeding? This probably tells you that you are dealing with ruptured ectopic. Now quickly tell me, how many of you think कि ruptured ectopic का मतलब है सीधा shock? बताओ. How many of you think कि ruptured ectopic का मतलब होता है patient is in shock? So बिल्कुल नहीं. Please remember, fallopian tube is a small structure. How much do you think is it going to bleed immediately? It's not spleen कि rupture हुआ और फटाक patient बेहोश हो गया. Yes, this is a small delicate organ. If it ruptures, it slowly bleeds. So for quite some time, the patient's vitals may be stable even with ruptured ectopic. Yes, so ये concepts हैं. जब तक ये नहीं आएंगे तब तक मैनेजमेंट के क्वेश्चन गलत होते रहेंगे. So please remember, there is a possibility of patients with ruptured ectopic to show orthostatic hypotension. So they will show blood pressure changes. There is a possibility for patients of ruptured ectopic to have completely stable vitals. And there is a possibility of patients of ruptured ectopic to come in shock. It totally depends on after how much time she presents. एक क्लासिकल बात है, जब मैं एपी शिप कर रही थी लेडी हार्डिंग में, तो जब भी हमें रात को एक एक्टोपिक की कॉल आती थी, वो हमें पक्का पता होता था रप्चर्ड होगी. बताओ क्यों? Almost every ectopic that comes at night in your duty is a ruptured ectopic. क्यों? पेशेंट को सुबह से पेन हो रहा होता है, बट दैट पेन इज माइल्ड, इट्स नॉट अक्यूट एब्डोमेन. यस, सो शी थिंक्स अभी ठीक हो जाएगा. शी कीप्स वेटिंग. फिर वो बोलती है अभी उसके साथ कोई है नहीं घर पे टू टेक हर टू दी हॉस्पिटल, मे बी दी हस्बैंड इज ऑफ टू वर्क एंड देयर इज नो वन एल्स. तो फिर वो सोचती है चलो हस्बैंड आएंगे देन आई विल गो टू द हॉस्पिटल. फिर वो सोचती है हस्बैंड आ गए चलो खाना वाना खा लेते हैं देन आई विल गो टू द हॉस्पिटल. और उतनी देर में क्या हो जाता है? उतनी देर में बुरी चीज हो जाती है. शी इज लॉस्ट अ लॉट ऑफ ब्लड, राइट? सो इट टोटली डिपेंड्स ऑन how much time she takes to present to you. Is it clear to everybody? Yes? Okay, so these could be the other findings. What can be the PA findings in your patient? What can be the PA findings? So PA findings can be tenderness, right? The tenderness may be in the lower quadrant, or it may be in the whole abdomen, depending on whether it is ruptured or not. There can be guarding, rigidity and rebound tenderness. Can you tell me from your knowledge of surgery, yes, can you tell me from your knowledge of surgery, what is the significance of guarding, rigidity and rebound tenderness? What is the significance? Jaldi batao. So the significance is peritonitis. These are obvious signs of peritonitis. And if a patient with early pregnancy has these obvious signs of peritonitis, it means she has ruptured ectopic. Okay, so it means she has ruptured ectopic. Very good. Apurva, Ayushi, Riya, good. Yes. So you should know what is the significance if these key words are written in the MCQ. They are telling you that she is a patient of ruptured ectopic, right? Okay. What would be the PV findings? What could be the pervaginal findings in your patient? So on a PV exam, there can be cervical motion tenderness. What do you understand by cervical motion tenderness? That when you move the cervix, the woman is going to have pain. What is this a marker of? This is a marker of salpingitis, inflammation of the tubes, right? So it is a marker of salpingitis. It's not a marker of ectopic pregnancy, okay? Uterus will be soft. It can be enlarged as well. Why? Because the uterus is undergoing the hormonal changes. Uterus को नहीं पता था कि pregnancy वहां तक नहीं आएगी. Yes, so the uterus is undergoing the hormonal changes. It can be enlarged, but it will be less than the period of gestation because the pregnancy is not inside the uterus. So it will be smaller than the period of gestation. Yes? What else? There can be adnexal tenderness. Okay, quickly. Do you know what is adnexa? So remember that tubes and ovaries are together called as adnexa. Right? So tubes and ovaries को together हम adnexa कहते हैं. So that area can be tender. And then there can be palpation of an adnexal mass. So you could feel that there is a mass in the adnexa. Now I want to know from you, out of the 4 findings in PV, which is most significant for ruptured ectopic? Batao? Out of all the findings, which is the most significant finding for ruptured ectopic? Anyone? So it is going to be adnexal mass. So the most significant finding here is presence of an adnexal mass. By significant, what do we mean? We mean that if an adnexal mass is present, then the suspicion that it is going to be ectopic pregnancy is going to be very high. Yes, so then the suspicion of ectopic is going to be very high, right? So the most significant here is adnexal mass. Is this clear? No, Aman. Guarding, rigidity, rebound tenderness, ये सारे per abdominal findings हैं. So if they are the findings, then it tells you that you are dealing with peritonitis. ठीक है? Okay. What are the differential diagnosis? What all can you think of when a woman comes to you with pain and bleeding, and early pregnancy or pregnancy? What do you think can it be? So please understand, one of the obvious differential diagnosis of ectopic pregnancy is abortions. Yes? So one of the obvious DD is abortion, जो हमने ऊपर भी लिखा, right? But what is the key thing here? In abortion, it is an intrauterine pregnancy. Yes, whereas when you talk about ectopic, it is a extrauterine pregnancy, right? So the DD is going to be abortions. The DD, as I have told you, if it is presenting with bleeding, it could be molar pregnancy. Typically, I will teach you molar, but especially when you talk about complete mole, here the uterine size is actually much more than the period of gestation, right? Ultrasound will finally help you confirm whether it is an abortion or a molar or an ectopic, right? But when we talk about pain, right? So a woman presenting with pain and we are thinking of ectopic, then what else is the DD? So one of the important things that you should know here is round ligament pain. जैसे कि ectopic में the pain was because of stretch of the fallopian tubes, the round ligament pain is because of pain of what? It is because of the pain of stretching of the round ligament. Actually, this is more common in the second trimester, and that's how it differentiates from ectopic. So round ligament pain is not usually seen in early pregnancy, more common in the second trimester around 12 to 16 weeks. But having talked about round ligament pain, what should you know about it? So when you talk about round ligament pain, you should know that this will be a pain which is more common on the right side. So because the uterus is dextro-rotated and stretching of the right round ligament is more. So more common on the right side. These patients will not have any bleeding. So if there is bleeding, you don't keep round ligament pain as a differential. You keep it as a differential when the main symptom is pain, right? This pain is classically exaggerated by movement. Okay, so she will say when I move, for example, she could say when I move in the bed, I change my posture, when I get up, or when I'm doing some exercise, right? So it is exaggerated by movement. it is typically relieved by application of heat, right? So it is typically relieved by the application of heat, right? Please remember, round ligament pain should be a diagnosis of exclusion. It should not be your primary diagnosis, but yes, once you rule out other things like ectopic, you could say that it can be a round ligament pain, and it is not associated with any significant laboratory changes except from physiological changes of pregnancy. There are no specific lab changes. Okay, so lab investigations will show the usual physiological changes of pregnancy. Yes, and then there is one pain that can happen anytime. Yes, so there is one pain that can happen anytime. What is that? That is appendicitis. Yes, so appendicitis is actually the most common cause of acute pain in pregnancy, right? So it is the most common cause of the acute pain in pregnancy. Who is going to tell me what is the typical pain of appendicitis? Because the history itself will tell you that it is likely to be a pain of appendicitis. What is it? So it is a radiating pain, है ना? So it's a migrating pain. कहाँ से कहाँ होता है? So periumbilical and then to the right lower quadrant, right? So it is a migrating pain which should help you making a diagnosis, right? So from periumbilical to right lower quadrant. What else will be a finding with appendicitis but will not be a finding with ectopic, will not be a finding with round ligament pain, and that is fever. Yes, so history of fever in your patient, yes, should make you think more towards appendicitis, right? And apart from that, as I said, when in doubt, ultrasound will help you make a diagnosis. So the criteria remains the same, which is when you do a compression ultrasound, yes, appendix, if it is more than 6 mm, then it is diagnostic. Is appendix compressible? No. So you do a compression ultrasound. So if you are seeing a non-compressible structure which is more than 6 mm in diameter, then you know that this is acute appendicitis. Management is just like acute appendicitis of outside pregnancy, which is appendectomy. Yes, so the management is also same. It is acute pain. The management is surgery. Right, so these are two important things that can cause pain. A third thing which you should know can cause pain in early pregnancy is, a hemorrhagic ovarian cyst. Yes, the third thing that can cause pain in the early pregnancy is hemorrhagic ovarian cyst. Now, do you all know that pregnancy may, there is a corpus luteum, yes, and this corpus luteum is vascular, okay, so it is vascular, and sometimes there can be bleeding within the cyst, so it could cause hemorrhage inside the cyst, okay, so hemorrhagic ovarian cyst can also cause pain. Typical history that the pain was or the onset of pain was after some strenuous physical activity. Right? For example, it could be some exercise or it could be even coitus. ectopic ka pain is not really related to physical activity. But here typically the patient will say that she was doing some physical activity and after that she had this sudden onset of pain, right? So usually the onset is after a strenuous activity, and for reaching to a diagnosis, again you need to do the ultrasound. So eventually, as I said, ultrasound will help you to finally make a diagnosis, but certain points in the history can point towards round ligament pain or appendicitis pain or a hemorrhagic ovarian cyst pain, right? Okay. Now, let us presume this patient has come to us with history of 6 weeks amenorrhea. Okay, so next patient coming to our OPD is a patient with 6 weeks amenorrhea, and she has pain and she has some spotting. Okay, so some small amount of bleeding she is having. Can you tell me what is the next step? Can you tell me what is the next step? What do you want to do? So the first thing you want to do is what we did as basics. The first thing is do a urine pregnancy test. Yes? So the first thing is do a urine pregnancy test, and 99% of times it is positive in ectopic pregnancy. So at least one thing we are sure of, that our patient is pregnant. Yes, but please remember, we've written 99% of times. There is a possibility that you get negative UPT and she has ectopic pregnancy. That is a possibility. Okay, so I'm going to write a negative UPT does not rule out pregnancy. Does not rule out ectopic is what I wanted to write. So if there is history, which is this, although the first test is a urine pregnancy test, but it does not help us in making a diagnosis of ectopic pregnancy. Yes? So can you tell me what should you do next to help you make a diagnosis? So I did a UPT, she is positive, she is pregnant. You are thinking of ectopic and other things. You have already done the PS and the PV exam. What should you do now? So as I said, any patient who comes to you with pain in early pregnancy or bleeding in early pregnancy, you must do a ultrasound. Very good. So you must do an ultrasound. Now quickly tell me, which ultrasound would you want to do for her? This is very early pregnancy. So we would do a transvaginal ultrasound, right? So it's early pregnancy. Abdominal scan will not help us pick up things because it picks up things later. So what we will do is ultrasound. बेटा history, PS, PV हमने कर लिया, वो सब ऊपर लिखा ना. So you have taken the history, you have done a general examination, you have done a PS exam, you have done a PV exam, right? So now you still have doubt whether it is ectopic or not, because PS, PV are not confirmatory. Yes? So now we are going to do an ultrasound. Now, you remember yesterday I taught you, yes, I taught you signs of early pregnancy and I said I will show them to you. Okay? This is the first sign that I taught you yesterday. It's called as the intradecidual sign. Yes? So you remember what I had drawn for you? I had drawn that you will see a small black structure and around that you will see white. So this is the gestational sac and this is the decidual reaction around it. Right? Then I said you will see the double decidual sac sign. So this is again the gestational sac and these are the two decidua. Okay? Remember that the double decidual sac sign and these are again given in your concept books. So it's all there for you. Okay. So this is the decidua. The double decidual sac sign is also sometimes called as the double ring sign. Okay. It is also called as the double ring sign. Then I told you the next is double bleb sign. Yes. Where you are seeing a gestational sac, and inside the sac you are seeing two blebs. So one is amniotic and the other is yolk sac. So there is an amniotic sac and there is a yolk sac. So this is the double bleb sign. Is this clear to everyone? Okay. So all these three signs we had done yesterday, and I had told you that these are signs of intrauterine pregnancy. They tell you that the pregnancy is intrauterine. So by doing an ultrasound, you can actually confirm that the pregnancy is intrauterine or not. Okay, so you will see the intrauterine signs of pregnancy. Okay. Can you tell me similarly what signs are diagnostic of extrauterine pregnancy? What sign is diagnostic of extrauterine? So if you see similar structures outside the uterus, right? So if I see a extrauterine gestational sac with embryo or yolk sac, then I have no doubt. So once I do an ultrasound and I see that outside the uterus there is a gestational sac, it also has inside it a embryo as well as a yolk sac. Yes. So then I am sure that this is extrauterine or ectopic, and I will start the treatment of ectopic. Right? If I see an intrauterine pregnancy, I will reassure her. Right? But I have to rule out abortion. Right? So I will reassure her after confirming viability, which we will talk about in the topic of abortion. So if you see an intrauterine pregnancy, you reassure her after you confirm the viability. If you see extrauterine pregnancy, which is diagnostic, then you start her with the treatment of ectopic. But there could be certain signs which are not confirmatory. For example, if I am seeing an empty uterine cavity, okay, so if I am seeing an empty uterine cavity and I am seeing a complex adnexal mass, yes, which also shows us the ring of fire, right? So let us see this image. Right. So look at this. So this is an image again from your concept book. This arrow which I am marking as red is showing you the empty uterus. There is nothing inside the uterus. And this arrow which I am marking is green is showing you the complex adnexal mass. Okay. So this is showing you the complex adnexal mass. Why do I say complex? Because it has some black areas and some white areas, which means some solid areas and some cystic areas. And if you put Doppler on it, so if on the same mass you put Doppler, then you get this. This is called as ring of fire sign, right? So this is the ring of fire sign. So these three things together are Okay, so these three things together are what? They are suggestive of ectopic but not diagnostic. Right? So these signs are suggestive of ectopic but they are not diagnostic of ectopic. Now can you tell me how will I proceed further? My patient is UPT positive. I am seeing an empty uterine cavity. I am seeing a complex adnexal mass. Yes, which is also showing me the ring of fire. What do I do next? Who's going to tell me? Let me see who can answer this question. What do you do next? So next here is going to be serum levels of what? HCG. This is where we will use the critical titer of HCG. Very good, Ayushi, as well as Apurva, right? So the next is serum HCG levels. If the serum HCG levels turns out to be more than or equal to 2000 milli international units per ml. You remember what is 2000? This was the critical value. Yes, so this was the critical value. Then I will make a diagnosis of ectopic and start treatment. So listen to me very carefully. If you are seeing ultrasound signs which are suggestive of ectopic but not diagnostic, and the serum levels are more than 2000, then you have to treat it like ectopic. Okay, then you have to treat it like ectopic. Okay. On the other hand, if HCG levels turn out to be less than 2000, then what do you do? If they are less than the critical value, then what do you do next? Can you think of it? Yes, repeat HCG in 48 hours. You have to keep doing the value of HCG every 48 hours and you see the trend. Yes, so remember in ectopic pregnancy, when you repeat HCG, okay, so when you repeat HCG, it shows a what? It shows a rise, but a slow rise, which means the value will not double. समझ में आया आपको? So थोड़ी सी increase होगी, but not doubling. It will not show doubling. Yes. Now doubling here does not mean 100%. When we say doubling, we usually mean around a 55 to 66% increase, right? But here it will be a slow rise. Okay. So a slow rise is again suggestive of ectopic. Yes, a slow rise is suggestive of ectopic. Okay. Whereas falling HCG here could mean what? It could mean a tubal abortion or non-viable pregnancy. Yes. So if the HCG value is automatically falling, it means either the tubal pregnancy is getting aborted, or if it is an intrauterine pregnancy, it's non-viable and it will also be aborted. Yes, is this clear to everyone? Okay. So if it's slow rise, it is suggestive of ectopic. You keep following it till it reaches what? Critical value. And then you will again repeat the ultrasound. Yes, so you keep doing serial HCG. repeat values, right? So you have to do serial HCG measurements, and once it crosses the critical value, you should do an ultrasound. It means, what am I trying to tell you? HCG values can never be diagnostic. Okay, HCG values can never be diagnostic. They are only suggestive. Yes, what is diagnostic? Diagnostic is ultrasound. Together, yes, they become a very good modality to make a diagnosis of ectopic pregnancy. Yes, is this clear to everyone? Yes, is the algorithm clear? So, what will you do when the HCG turns out to be above the critical titer? And what do you do if the HCG turns out to be less than the critical titer? Yes, is it clear to everybody? Okay. Now, the third possibility. So, if you look at this, I said you are doing an ultrasound in your patient. One possibility is that you see an intrauterine pregnancy. One possibility is that you see an extrauterine pregnancy. One possibility is you see findings which are suggestive of ectopic but not diagnostic. So we have done that. Can you tell me what could be the fourth possibility on ultrasound? What is the fourth possibility on ultrasound? The fourth possibility on ultrasound is you don't see anything, by which I mean you see empty uterus and normal adnexa. So there is nothing inside, there is nothing outside, but she is pregnant. Can you tell me what will you do in such a patient? So fourth possibility on ultrasound is you're not seeing anything inside, you're not seeing anything outside, but UPT is positive. Ab kya kare? So again here you have to do the same thing. You will have to do serial HCG measurements. Okay, so you will have to do serial HCG measurements. Yes, so jaldi se mujhe batao, are all the four possibilities on ultrasound clear to you, and do you now understand what you will do with the patient? Yes, so you are going to do the serial HCG measurements to see whether it is a viable pregnancy, a non-viable pregnancy. Let it reach the critical value, then repeat the ultrasound. Okay. Sanskriti, ring of fire only tells you that the structure has high vascularity. Please understand that this ring of fire can also be seen in a corpus luteum. Yes, so this can also be a finding of corpus luteum. So it does not mean that it is an ectopic pregnancy. Riya, ectopic is considered under abortions. It's a non-viable pregnancy, but in the history you will specify that it is a ectopic. So when you take detailed history, you will specify that it was a ectopic pregnancy. Is it clear, bache? It is basically a non-viable pregnancy, right? Okay. Now, there is one more thing that I want you all to understand, and that is, suppose a patient comes to you with ruptured query ectopic. So you don't know, right? But why I am saying ruptured is because you've taken her vitals. Yes, complex adnexal mass can be anything. Okay, a pregnancy is not a complex mass. A pregnancy should show you a gestational sac, and inside the sac you should see the yolk sac, you should see the embryo. Okay, right. So vitals are unstable. So let us say, I won't say ruptured ectopic, I will say a patient has come to you with early pregnancy, right? And history of bleeding, pain, right? Her vitals are unstable. And on PA exam, you have findings which are findings of ruptured ectopic or peritonitis. So PA has findings of peritonitis, which means it could be guarding, it could be rigidity, and it could be rebound tenderness. Can you tell me, what should you do with this patient? So look at this. She is a patient of early pregnancy. Okay. She has come to you with bleeding and pain. On examination, her vitals are unstable. And a PA exam shows you guarding, rigidity and rebound tenderness. So which means your probable diagnosis is what? Query, ruptured ectopic. I want to ask you, what are you going to do next for this patient? What are you going to do next for this patient? So please understand this. Once you see an unstable patient, okay, with obvious peritoneal signs, so she is unstable and she has obvious peritoneal signs, there is no need to do an ultrasound. It means there is a peritoneal collection. Okay, इसका मतलब ही है कि पेरिटोनियम के अंदर collection है. There is no need to do an ultrasound. You have to quickly shift her to OT and operate. You have to find out the reason of the cause of the bleeding and you have to stop it. Yes, needless to say, whenever you see an unstable patient, the most important thing becomes stabilization. But these things have to go hand in hand. Okay? So stabilization means large bore IV cannula. Right? Stabilization also means you start her fluids, arrange blood. But please understand, ये सब करते करते ही उसको ओटी भी शिफ्ट करना है. ऐसा हमारा बिल्कुल मतलब नहीं होता है कि आप पहले उसे आईवी फ्लूइड्स दो, उसका बीपी नॉर्मल लेकर आओ, उसके बाद ओटी लेके जाएंगे. Yes, do you understand this? The two things have to be done together. You have to secure IV lines, you have to start IV fluids, you have to shift her to OT, and you have to arrange blood. This has to be done side by side, not one after the other. Is it clear to all of you? But in such a patient, there is no need of ultrasound. Please don't take her for an ultrasound. Okay? This will be a gross error. Is it clear to everyone? Yes? Okay. Suppose this patient does not have, so let's say there's another patient who comes to you with similar complaints, right? She has amenorrhea, she has bleeding, okay? So amenorrhea hai, bleeding hai, unstable vitals hai, yes? But no obvious peritoneal signs. So your patient has amenorrhea, she has bleeding, she has unstable vitals, but there are no obvious peritoneal signs. Right? Then, although you are suspecting still a ruptured ectopic, because whenever it's pregnancy, yes, so they will also probably give you that her UPT is positive. They will give you this. What test can you do here to see whether it is ruptured ectopic or not? क्या कर सकते हैं? So one is definitely yes, you can take her for a fast. Okay? Yes. So fast is a type of an ultrasound that you do when a patient comes with unstable vitals, but there are no obvious peritoneal signs. But apart from fast, what can you do? So apart from fast, what you can do in this patient is this. Okay, so this is again an image from your concept book only. Yes, so this is an image from your concept book only. Look at what we are doing. So this is the woman that I am talking about. She has amenorrhea, a positive UPT, unstable vitals. I am putting IV lines and starting fluids. Yes, I am arranging blood, and meanwhile I am doing this. What is this? This is culdocentesis. Yes, culdo means what? It means pouch of Douglas. Centesis means aspiration. So you know, the pouch of Douglas is the most dependent part of the female pelvis. Right? So it is most dependent part of female pelvis. So whenever there is a rupture, the blood is going to accumulate in the pouch of Douglas. Yes, so blood is accumulating in the pouch of Douglas. And I am taking a syringe and a wide bore needle, and I am going through the posterior fornix. Yes, so I am going through the posterior fornix. When I pierce the peritoneum, when I pierce the posterior fornix, I enter the pouch of Douglas. So now I will aspirate. If you aspirate blood, yes, so if you aspirate blood which does not clot on keeping, so you keep it only for 10 minutes. जब तक आप बाकी सब कर रहे हो, IV line लगा रहे हो, fluid लगा रहे हो, right? So if you aspirate blood which does not clot on keeping, then this is a marker of hemoperitoneum. You have to quickly then shift her to OT. Yes, so sometimes there is no need to shift the patient to ultrasound. You can quickly do the culdocentesis and see if there is bleeding there or not. Yes, please remember, why do I say if it does not clot on keeping? What will you understand if it clots on keeping? आपने रख दिया syringe को, 10 मिनट बाद देखा वो blood clot हो गया. What does that mean? It means you have taken that sample from one of the pelvic vessels. आपने vessel में से aspirate कर लिया है. That is not hemoperitoneum, right? So if it clots on keeping, it means you have entered a pelvic vessel and you have aspirated blood from there. Okay, so this could be one of the other ways of documenting hemoperitoneum. Yes, and fast, you all know, fast is a quick ultrasound. Usually it is done in trauma patients, but it can be done any time when you are suspecting internal bleeding, but there are no peritoneal signs. So fast is an ultrasound that you do when you suspect intraperitoneal bleeding, but there are no obvious signs of peritonitis. Yes, so I said in such a scenario when there are no obvious signs of peritonitis, you could do a culdocentesis or you could do a fast. Is this concept clear to everyone? Yes, I hope you will not make a mistake. Is it clear, bacha? Okay. So this gives a complete diagnostic algorithm that you should follow for different kinds of patients who come to us with bleeding and pain, and if you are suspecting ectopic. Is this clear to everybody? Okay. Then There are certain other investigations that you should know that can be done but are not practically done. So practically we are using TVS and serial HCG levels for diagnosis of ectopic, right? So this is going to be the investigation of choice. But if we have to pick one answer as investigation of choice, तो क्या होगा? One answer में you will mark TVS, because serial HCG alone is not useful. It has to be clubbed with TVS. Is it clear? So IOC, if you can give two answers, then it is TVS and serial HCG. If you have to give only one answer, then it is going to be TVS. Okay? Is this clear? What is considered as gold standard investigation? The gold standard investigation for ectopic is diagnostic laparoscopy, right? But it is actually too invasive. Most of the times we don't need laparoscopy. Most of the times ultrasound and HCG together are good to make a diagnosis, right bacha? Okay. Then serum progesterone levels is not useful. Now this is something that these central institutes are fond of asking. See, what we say is that if the serum progesterone levels are more than 25 nanograms per ml, then this is an intrauterine pregnancy. Okay? The problem arises if the levels are less than 5 nanograms. Okay, so if the level is less than 5 nanograms, then this can be ectopic, but it can also be a abortion. So because the progesterone levels don't help us to differentiate ectopic from abortion, this test is not useful, right, in ectopic pregnancy. Is it clear to everyone? Yes or no? जवाब दिया करो, बीच बीच में गायब हो जाते हो. Okay? Then yet another thing that you have to know where you get confused, there is a terminology which is called as colpotomy. Okay? Colpotomy is colpo and otomy. Otomy means opening up. So colpotomy is opening up of pouch of Douglas, right? Do we do this for ectopic pregnancy? Good, good. Okay. So no, this has no role in ectopic. Please remember, what procedure are we doing in ectopic at all if we are doing? We are doing culdocentesis, not colpotomy, right? So culdocentesis is what is done for ruptured ectopic. Colpotomy is something that you do to drain a pelvic abscess, right? So जब pouch of Douglas में abscess हो, thick pus हो, that's when you need to cut it open and drain the pus, right? So colpotomy has no role in ectopic. Okay? So don't get confused here, right? So these are some things that you should know about the investigations, right? Now once we know the investigations, let us quickly see what is going to be the management of ectopic, because the most important thing was to understand how to make a diagnosis. Once you know or understand that, the rest of it actually becomes easy. So there are three forms of management of ectopic. Okay, so one form is medical management, another is surgical management, and then third is expectant management, right? Now, out of the three types of management, which is the most preferred one? Medical. So, medical management is preferred. Can you think of the reason why? Because by doing a medical management, you can preserve the fallopian tube. Yes? So, you can preserve the fallopian tube of the woman if you're doing a medical management. So, generally, this is what we prefer. Expectant management is least preferred. Why? Because there is always a risk that you are not, you are missing out on the ectopic and it might rupture and you may lose the patient, right? So least preferred is expectant. The most preferred is medical. When do you do surgical? I will tell you. Now, the first thing that you should know is, when do you do expectant management? So the answer is rarely. What are the criteria required so that your patient is eligible for expectant management? The criteria are, number one, there should be no visible gestational sac. Okay? So if you are seeing a gestational sac outside the uterus, you don't do expectant management. Second requirement is HCG levels should be less than 200 and it should be a falling trend. Right? So the absolute level of HCG should be less than 200 and it should be a falling trend. Falling trend से क्या मतलब होता है? That if you do serial measurements after 48 hours, वो अपने आप ही कम होता जा रहा है. So if you realize, ये दोनों चीजें आपको क्या बताती हैं? ये दोनों चीजें बताती हैं that it is actually not a confirmed ectopic. ये हम उन conditions में कर रहे हैं जिनमें हमें प्रेगनेंसी की लोकेशन ही नहीं पता लग रही. Yes, because probably it's too small, you're not able to pick it up. And it is non-viable because the HCG is falling. So it's a pregnancy in an unknown location, but it is a falling trend. So it is a non-viable pregnancy. Obviously, for expectant management, the vitals have to be stable. Right? So the vitals have to be stable. So this is a very rare thing in ectopic. Never mark expectant management as your treatment of choice. Right? Going on to the other extreme. The other extreme is medical management. What are the criteria to make a patient eligible for medical management? Okay. The first is stable vitals. Medical management is never done if the woman is hemodynamically unstable. Okay. It has to be an unruptured ectopic. If your patient has ruptured ectopic, even if vitals are stable, no role of medical management. Once you say ruptured, it has to be surgical. Third, absolute value of HCG should be less than 5,000 milli-international units per ml. Okay, so the absolute value should be less than 5,000. The gestational sac should be less than 4 centimeters in size. So if you are able to see a gestational sac, then the size should be smaller than 4. If it is 4.5, 5 centimeters, no medical management. Okay? Then, what about if you are able to see cardiac activity inside the gestational sac? Now, this is something that you have to very carefully listen to me. Okay? If you are seeing a gestational sac with cardiac activity, then the preferred treatment for it is surgical. ठीक है, प्लीज ध्यान से सुनेंगे, नहीं तो बच्चों के कॉन्सेप्ट क्लियर नहीं होते. राइट, इफ यू आर सीइंग एन extra uterine, whenever I'm writing sac here, I mean extra uterine. Yes. So if you are seeing an extra uterine G-sac which is also having cardiac activity, the preferred treatment is surgical. Is it clear to you? Now, in case you want to do medical management, you can, but it is not preferred. In case you are, so preferred treatment is surgical. In case you are wanting to do a medical management, then it should be a gestational sac which is less than 3.5 with cardiac activity. Right? So please understand again. In case cardiac activity is present and you want to do a medical management, the sac size criteria is different. So 4 centimeters is the criteria if cardiac activity is absent, and less than 3.5 is the criteria if cardiac activity is present. जल्दी से मुझे बता दो कि ये बात समझ में आई कि नहीं. So पहली चीज सबसे इंपॉर्टेंट है कि अगर कार्डियक एक्टिविटी है तो मेडिकल मैनेजमेंट मत करें, आप सर्जिकल करें. अगर आपको मेडिकल करना है, इट हैज अ हायर चांस ऑफ फेलिंग, मगर अगर आपको फिर भी करना है, देन द सैक साइज शुड बी लेस देन 3.5. इज इट क्लियर? सो दीज आर द क्राइटेरिया फॉर मेडिकल मैनेजमेंट. कमिंग टू क्राइटेरिया फॉर सर्जिकल मैनेजमेंट. सो एक तो मैं लिखी चुकी हूं, एक्स्ट्रा यूट्राइन जी सैक विद कार्डियक एक्टिविटी. सेकेंड, ectopic pregnancy with unstable vitals. The management is surgical. Third, ectopic pregnancy which is ruptured, right, is again always surgical. Ectopic pregnancy with family complete, which means she has no desire to have more babies, then your preferred treatment should be surgical. Can you think of reason why? Because I said one of the most high risk factors for ectopic is previous ectopic. तो अगर आपने मेडिकल मैनेजमेंट किया है और ट्यूब को सेव किया है, then it's very high likely that she will again develop an ectopic pregnancy. Yes? So इसीलिए if the family is complete, our preferred treatment would be surgical. Last, for surgical, I will write, when criteria for medical management not met, okay, or when medical management fails. So if medical management criteria are not met, or if medical management fails, then obviously you have to go ahead and do surgical. Yes? अब जल्दी से मुझे बता दो, because then I will take only 10-15 minutes more. जल्दी से मुझे बता दो, are the criteria clear or not? Because इस पे MCQs आते हैं. So criteria for medical, criteria for surgical, and criteria for expectant. So jaldi se give me a thumbs up and tell me, have you understood this? Because you will frequently get questions on it. Yes, I'm waiting. Quickly tell me. Okay. All right, good. The next thing you have to know is, एक बार decide कर लिया कौन सा management करना है, तो उसके अंदर करना क्या है? So what exactly are you going to do in the medical management? Yes? So medical itself means you're going to give a drug. So what drug are we going to give? We are going to give methotrexate. Right? So we are going to give methotrexate. 50 milligram per meter square or 1 milligram per kg is the dose. It is given as an IM injection. We are going to use single dose regime. Okay, so we are using a single dose regime, right? जिस दिन आप इंजेक्शन methotrexate देते हो, we call it as day 1. Okay, we call it as day 1. What will you do after this? On day 4, you will send her serum HCG. And on day 7, you will again send her serum HCG. Okay. Now quickly tell me, if your medical management is successful, what do you think should happen to day 7 value? If your medical management is successful, what should happen to the HCG value? It should fall. Yes? So day 7 value should fall. Now we go to the depth. Exam ke liye we need to know how much will be considered as successful. The day 7 value should fall by at least 15% of day 4 value. So minimum requirement hai 15%. Okay. If it is falling by 15% or more, your medical management is successful. Okay. But what if HCG value falls by less than 15%? So if it falls by less than 15%, now what do we do next? Let's say fall to hua, but it was only a 5% fall or only a 10% fall. So ab kya karna hai? Now you are going to give repeat methotrexate, right? Again you will call it as day 1 and you will again do the same things. Day 4 pe HCG, day 7 pe bhi HCG. So you are going to exactly do the same thing. So we keep doing like this until we give a total of 3 doses of methotrexate. So अगर आपने 3 बार methotrexate दे दिया है, but still the decline is not optimum, right? So total of 3 doses of methotrexate, but HCG decline is suboptimal. Then this is what is considered as failed medical management. Is this clear? So this is what is called as failed medical. So a total of 3 doses, right? But the fall is suboptimal. So this is what is failed. So you should know what is successful medical management. You should know what is failed medical management. Okay. Before I go to surgical, quickly tell me, why are we comparing day 4 and day 7 values? Why did not I follow day 1 and day 4 value or day 2 and day 4 value? So please understand this. In the first 4 days, HCG can actually rise. So क्या हो रहा है? जब वो sac destroy हो रहा है, initially it releases HCG. Okay. So in the first 4 days, the HCG may rise, which is a normal reaction to injection methotrexate. So we will not take HCG values between the first 4 days. We will take it on the 4th day because that is when the decline starts. Okay, so that is where the decline is going to start. Is it clear to everybody? Yes, is medical management clear? Quickly tell me, is medical management clear, bache? Give me a thumbs up if medical management is clear. Going on to what are we going to do in the surgical management? So surgical management में the first thing you have to know is that we prefer laparoscopy to do the surgical management. Okay, so to do the surgical management we prefer laparoscopy. But can you tell me under what condition would you do laparotomy? So we will do a laparotomy if vitals are unstable. Is this clear? Right? So generally we will do laparoscopy, but if the vitals are unstable, then we can do laparotomy. Right? So ऐसे we will reach the fallopian tube. Now what are we going to do on the fallopian tube? So generally we will do salpingostomy. So inside on the tube, we prefer salpingostomy. Look at this. This has the word ostomy in it. Do you know what is ostomy? To make a small opening. And you make a small opening. How small? It's actually a 1 centimeter opening in the fallopian tube. Yes. And through this small opening, you are going to remove the products of conception. Yes, so you make a small opening, remove the products of conception, and then you leave the opening without suturing. So opening को बंद नहीं करना. Why? Because if you are going to use sutures, sutures are foreign material and tubes are very delicate. So they will form more and more of adhesions. So no suturing, you leave it open. That is why it is called as an ostomy. Yes? And it will heal by itself. So this is done in order to reduce the recurrent risk of ectopic. If you close it, the chances of repeat ectopic are very high. Okay? Now, ये जो opening हमने बनाना है, this is made on the anti-mesenteric border of the fallopian tube. What do you understand by the anti-mesenteric border? एक तरफ fallopian tube पे peritoneum attached है, उस तरफ incision नहीं देना. You will give the incision on the site which is opposite to the peritoneal attachment. So the anti-mesenteric border. Okay? No, Prerna, if the day 7 value has decreased and if it has decreased by 15%, then there is no need of further treatment. Then it is a successful medical management. You only give repeat dose when the fall is less than 15%, Prerna. Okay? Yes, Prerna? So if the fall is less than 15%, then you will give additional doses. Yes? Okay. So generally in the surgery, we prefer salpingostomy. But in your exams, they can ask you, when will you do salpingectomy? Right? Jectomy means you are going to remove the damaged tube. Tube को वहां नहीं छोड़ना, we will remove the tube itself. Can you tell me under what conditions will you actually do a jectomy and not ostomy? Okay? So this is number 1. If it is a ruptured ectopic. भाई अगर एक बार ट्यूब रप्चर हो चुकी है तो आप इंसिजन कहां पे दोगे? You can't give an incision. Okay? Second, if the family is complete, yes, very good Ayushi. We don't want to leave the damaged tube inside because it will increase the risk of repeat ectopic. Third, if there is extensive damage to the fallopian tube. Right? or if the sac size is too big. Usually we say if it is bigger than 5 centimeters, it's too big to do a ostomy. So these are the 4 conditions where you will do a jectomy, right? So jectomy means you have to remove the damaged tube. So you will do it when it is ruptured ectopic, when the family is complete, there is extensive damage to the fallopian tube, so it's bleeding from everywhere, and if it's a big sac size. Yes, is it clear? So these are the things that you should know about surgical management. The last is, what are you going to do in the expectant management? So as the name suggests, what is expectant? That you are going to just wait and watch, okay? Because anyways the HCG levels are falling. So what you do in the expectant management is, number 1, monitor the patient vitals and symptoms. And second, you keep monitoring the HCG levels. So every 48 hours, you should repeat HCG till it returns to normal. Right? So repeat HCG every 48 hours till the value returns to normal. Yes? So this is what you do in expectant management. Is this clear to everyone? Yes? Okay. The last 5 minutes before we actually say good night and goodbye is this. There are rare things to happen. The rare things are cervical ectopic, abdominal ectopic, and ovarian ectopic. Right? So as I said, they are rare things. Their incidence is also quite rare. What I want you to know here is just a few things about them, especially the names of the criteria used to make a diagnosis. Okay? So for cervical ectopic, the named criteria are Pallmann's criteria and Rubin's criteria. The more recent are Pallmann's, Rubin's are older criteria. Okay? So the named criteria we use, so these are the criteria for a diagnosis of primary cervical ectopic. What do you understand by primary cervical ectopic? It means प्रेगनेंसी शुरू से ही सर्विक्स में है. ऐसा नहीं है कि पहले प्रेगनेंसी यूट्रस में थी एंड देन इट हैज कम टू द सर्विक्स. नो. So right from the beginning, the pregnancy has been in the cervix. That's what we mean when we say primary cervical ectopic. Okay? The named criteria for abdominal ectopic are Studi-Ford criteria. They are again criteria for diagnosis of primary abdominal ectopic. Primary means the pregnancy has implanted in the abdomen only. Okay? It has not come from anywhere else, not from the fallopian tube, not from the uterus. Right? Ovarian ectopic. The named criteria are Spiegelberg criteria. So sometimes these criteria are asked in the exam, so you should know the name. Please understand the concept of primary, and then you will be able to, even if you don't know the entire details, you will still be able to make a diagnosis, you'll be able to mark it. For example, what do you think Studi-Ford criteria will say? So Studi-Ford criteria will say that the fallopian tubes should be normal, the uterus should be normal, yes? So that, we are trying to say that the pregnancy has not come from the fallopian tube and not come from the uterus, right? So, the pregnancy should be related to the peritoneum. The tubes, ovaries and uterus should be normal. Do you understand the concept? Similarly, what do you think ovarian ectopic criteria will say? They will say the fallopian tube on that side has to be normal. So that we are trying to say that pregnancy has not come from the fallopian tube. Then in the gestational sac on histopathology, you should be able to see the ovarian tissue. Yes? So जब आप उसको specimen भेजोगे, pathologist को ovarian tissue दिखेगा उसके sac में. What else will it say? It will say that the sac should be in the location of the ovary. Right? So it should be in the location of the ovary. And lastly, it will say that the sac should be connected to the uterus. Yes? So it should be connected to uterus, by which ligament is the key. Do you all know which ligament attaches the uterus and the ovary? It is the ovarian ligament. So the gestational sac should also be attached to the uterus by the ovarian ligament. Yes? So if you understand the concept, it's not difficult to mug up what the criteria will say. You have to understand the meaning of primary. What is primary abdominal? What is primary ovarian? What is primary cervical? Right? So similarly, what would Palman's criteria say? So Palman's criteria will say that here it is actually going to be the reverse. The internal os will be closed. So that we are saying that pregnancy is not coming from the uterus. Yes? External os will be partially open. Because that's where the pregnancy has gone from. Right? Pregnancy will be attached to endocervix. So it has to be tightly attached to the endocervix to prove that this is where it has been from the beginning. And lastly, there will be no uterine cramps. There is no pain. It is painless bleeding. Why? Because the pregnancy is not in the uterus. So uterus is not trying to throw it out. So there will be no pain, but there will be bleeding. Yes? So quickly tell me, do you now understand what is the concept of the word primary cervical or primary abdominal or primary ovarian? Yes? Quickly tell me if you have understood. Okay. The last things that I have to tell you here is the management. So please remember, the treatment of choice for cervical ectopic is medical, as long as the patient is stable. If the patient is unstable, then you have to do a surgery. Yes? Whereas for ovarian and abdominal pregnancy, the treatment of choice is surgery itself. Right? So for abdominal and ovarian, the treatment of choice has to be surgery. One interesting fact about abdominal pregnancy is, out of all ectopics, you know, the abdominal pregnancy can go to largest gestational age. The pregnancy can actually keep growing in the abdomen. And sometimes, you know, these women will come in the second or probably early third trimester. Right? So, abdominal pregnancy is the site, or ectopic is the site where pregnancy can go to the longest gestational age. It should not be largest, it should be longest. अब बच्चे कई बार यहाँ गड़बड़ करते हैं. Sometimes when we ask you which ectopic can go to the longest gestational age, they go and mark interstitial. Please remember, interstitial is the answer when you are comparing the sites in the fallopian tube. When you are comparing in general, then the answer is abdominal. As I said, it can go to the second or early third trimester as well. Yes? So don't do that mistake. When we ask you which ectopic can go to the longest gestational age, it will be abdominal. Please remember, abdominal pregnancy is an obstetric emergency. जिस भी POG पे वो present करेगा, it is an emergency. It has to start. You have to take her up for a surgery. You have to do a laparotomy. Okay, so you have to do a laparotomy, and what will you do? You will remove the fetus or the baby, but you will leave the placenta in situ. So you will remove the baby, but placenta is left inside. Can you tell me why? Why are we going to leave the placenta? Because in such pregnancies, the placenta is taking its blood supply from vital organs. It could be liver, it could be spleen, it could be bowel. So if you try and remove it, there will be a massive hemorrhage. So you leave the placenta in situ, it will undergo autolytic digestion. Yes, so it will undergo autolytic digestion. Yes, is it clear to everyone? अच्छा, जल्दी से बताओ, अल्ट्रासाउंड पे abdominal pregnancy कैसे देखोगे? So please remember this basic fact. Normally, the pregnancy is inside the uterus. और uterus के आगे क्या होता है? Bladder. Yes, so uterus होता है, uterus के आगे bladder होता है. So the pregnancy is close association to the bladder. Right? But there is myometrium in between. Right? Now, in an abdominal pregnancy, this myometrium is not going to be present. Yes? So, uterus alag chota sa niche baitha hoga, and there will be pregnancy on top of it. Right? And there will be no surrounding myometrial tissue. Yes? Okay. So this is it for today. This is what we should know about ectopic pregnancy. Okay. Do you want to do 1 or 2 MCQs? Do you want to do 1 or 2 MCQs? Yes or no? Or you're tired? Okay. एक बार देख लेते हैं. No, we don't continue ectopic pregnancy. Okay. All right. This is a question that I have already taught to you in the class today. Yes, that, if a patient is coming to you for preconceptional counseling and she's got a karyotype done, and if she turns out to be balanced 13-13 translocation, what is the likelihood of abnormal karyotype? It is 100%. So if it is 13-13, 21-21, then the risk of abnormal karyotype is 100%. That's what is the answer here. You are, okay, I think we did this one. Okay, so I think as of now, these are the questions we have. Okay, so I will bring some more questions for tomorrow's class. So we will continue with bleeding in early pregnancy. Yes, and we will do the other topics which cause bleeding, which is abortions and molar pregnancy. Okay, so thank you so much everyone. Good night. It was a pleasure to teach you all. Go back and read the concept books. Do the book back exercise as well and try and solve some MCQs. Okay. If it is surely in the first 35 days, you simply ask her not to take it further and you can continue the pregnancy. Okay. Always remember that the teratogenic period is from 3rd week to 8th week. So if there is some exposure before that, either it will cause a complete abortion or it will do nothing to the baby. right? So she can continue and you can follow up with ultrasound. Okay? Right, chalo. Good night everyone. I see you tomorrow at 5 p.m. Bye-bye. Take care. Best wishes. Okay?